Afternoon and welcome to NHS West Yorkshire Integrated Care Board. We're here in Ilkley today on a very sunny day. Hello, my name's Cathy Elliott. I am Chair of NHS West Yorkshire Integrated Care Board and Deputy Chair of our Health and Care Partnership. My colleagues around the table today represent a variety of people who are in leadership roles across health and care in West Yorkshire and supporting us as NHS West Yorkshire as a commissioner and convener of our partnership. We are in a pre-election period, so our agenda today is very much business as usual, and it is in line with NHS England's pre-election guidance. We continue, though, to continue our work and our board meetings and discussions around the full purposes of an integrated care system, around reducing health inequalities, and we particularly had a board development discussion early today with colleagues in public health on our plans. Also managing unwarranted variation in care, using our collective resources wisely and ensuring value for money for the public purse. And we'll be hearing later about our financial activities and plans. And also ensuring a broader contribution to social and economic development in West Yorkshire. So we have a number of apologies today. Unfortunately, we do have some illness as well as people on leave, understandably, in this holiday period. Laura, would you just share with us the apologies and any deputations today?
Thank you. Yes, the apologies we've had today are from Arunangsu Chatterjee, Robin Tuddenham and Neil Smurthwaite is deputising, Therese Patton and Nancy O'Neill is deputising, Richard Vortree, James Thomas, Ian Holmes, Anthony Keeley and Lou Auger is deputising, and Councillor Tim Swift. Thank you.
And just for the benefit of people who've joined us today to observe, welcome to you. Thank you for taking the time to come and join us for our meeting. And for anyone watching live streamed on a record online, thank you for taking an interest in our work. I'm just going to go around the table out of courtesy to ensure that our board members introduce themselves. Karen, would you start, please?
Hello everybody, I'm Karen Jackson. I'm the Chief Exec at Locala and the Community Services Sector Lead on this board. Thank you.
Hello, my name is Fatima Khan Shah. I am the West Yorkshire Inclusivity Champion, which is a role shared across the Combined Authority and the ICB, focusing on equity and social justice.
Good afternoon everyone, I'm Sarah Monroe. I'm the Sector Lead for Mental Health, Learning Disability and Autism.
Hello, I'm Becky Malby. I'm an outgoing non-executive member. My remit is around future generations and I have particular interest in primary care.
Hi, Tim Riley. I'm the place lead for the Leeds, City Leeds.
Good afternoon, my name is Beverly Geary. I'm Director of Nursing for West Yorkshire ICB.
Hello everybody, I'm Kim Shuttler. I'm the VCSE Sector Lead.
Hi everyone, I'm Rachel Spencer-Henschel. I'm the Director of Public Health for Kirklees and I'm the Sector Lead for the West Yorkshire Directors of Public Health.
Hello, I'm Lou Auger and I'm the Deputy Director for Planning and Performance. I'm here deputising on behalf of Anthony Keeley.
Good afternoon everybody, my name is Jo Webster and I'm the Place Lead for Wakefield District.
Good afternoon everyone, I'm Majid Hussain, one of the non-exec members, and I look after people and health inequalities. Thank you.
Hello, I'm Jonathan Webb, Director of Finance and Deputy Chief Executive at West Yorkshire ICB.
Hello, my name's Rob Webster, I'm the Chief Executive.
Hello, I'm Laura Ellis, Director of Corporate Affairs for the ICB.
Everybody, Sam Ramsey, Head of Corporate Governance.
Hi, I'm Jane Madeley. I'm a non-exec member and Chair of the Audit Committee.
Hi, I'm Tom Reardon. I'm Chief Exec of Leeds City Council and Sector Lead for the Local Authority Chief Execs.
Hello, I'm Carol McKenna. I'm the Police Lead for Kirklees.
Good afternoon, Nancy O'Neill, Director of Partnership and Place, Bradford District in Craven, for Therese Patton.
Afternoon, Neil Smurthwaite, Deputy Place Lead for Caldwell Cares.
Good afternoon, I'm Kate Sims. I'm the Director of People for the ICB. Thank you.
Hi, I'm Hannah Davis. I'm Chief Exec at Health Watch Leeds and I'm here on behalf of the 6 local Health Watch working across West Yorkshire.
Hello, I'm Brendan Brown. I'm the Chief Exec Lead for the Acute Sector, Wyatt.
Great. Thank you very much, colleagues. Really welcome you introducing yourself so we can remind ourselves around the table the vast experience and expertise that we have, as well as to ensure that people watching the meeting today understand our roles. Can I ask if there are any declarations of interest in relation to today's agenda? No? Okay, none. Thank you. And just a reminder to all board members to use the online portal to keep their declarations of interest live. And again, grateful to the governance team over many months ago introducing that for us, which is really, really helpful. And also to explain, we have colleagues here from our governance team who are supporting us today as well, and our comms colleagues in the background there. So we next go on to item 9, which is our minutes of our last meeting on the 19th of March. And just to explain why we're on item 9 when we've only just started the meeting, it is because we had a meeting beforehand in private, as we do as a board each time, to discuss particular items which fall under that remit. And thank you for board colleagues for the discussions earlier today. So we have the minutes of our board meeting in public on the 19th of March. Colleagues, are those an accurate reflection of our meeting that day? I think we've got some corrections that have come through in advance of the meeting. Laura, if you'd just share those. Thank you.
Thank you. Yes, just for completeness. So I'm referring to page 10 of the minutes, and there's a series of bullet points on that page. We are going to slightly amend the wording for the second and third bullet points. It doesn't change the context of what's there, it just provides a little bit more clarity. And then we're also going to add an additional bullet point on there, which is in respect of children and young people access. And to say where the target was being exceeded, it would be helpful to identify data around the needs of those who were unable to access. So we'll make those changes. Thank you.
Thank you. And thank you, Becky Mulby, for those comments. So with those amendments, are we happy to approve those minutes? Thank you. Nods around the table. The action log, Laura, from the 19th of March, is there anything to note?
Thank you. Yes, for colleagues around the table, it's page 68 of the board pack. So I think the first open one is number 19. Anthony's not with us today. I don't know whether, Sarah, you have an update around the reporting of staff turnover and sick leave, or whether that's still an open action. Thank you. We'll note that in terms of the glitch in reporting. Thank you. And then the next open one is number 20. If I could just pass to Kate, please, around that action.
Thanks, Laura. This action was that I would share a copy of the staff survey action plan. This is for the ICB with the board. So it was presented at the EMT, our executive management team, last week, and that was actually supported and signed off. So I'm now in a position to do so. So we'll get that sent out. Thank you.
Thank you. That's it. The other ones we're still waiting for colleagues to be with us. Thank you.
Okay. Thank you. And in terms of matters arising, we did have a discussion at our March meeting on a report that Beverly Geary shared with us on maternity services. I know, Bev, you're going to touch on that later when we get into our performance reporting and risk management. We also note we had an update on the Fuller Delivery Board, and that is something that is going to come to us in September. Becky, I don't know if you want to update on that, because I know you talked about that at the Quality Committee.
Yeah, we did. So we've done some work at the Quality Committee, particularly looking at fairness across the whole of West Yorkshire around access. And of course, what we know around our data around primary care is we know who turns up. We don't tend to know who doesn't turn up or who's tried to turn up. So we've asked the Fuller Board to have a look at ensuring that across West Yorkshire, our primary care colleagues have access to equal access to around business intelligence and resources to be able to understand people whose needs we might not know about, as well as those who are trying to get through. But also if people are trying to access and don't access, what happens to them.
Thank you very much. Our colleague Ian Holmes is unfortunately not here today due to sickness, but this is something Carill, with Ian and other colleagues, we'd asked for the Fuller Delivery Board to come back to our September meeting. And if anyone's interested who's watching the meeting, wondering why our times during the year are changing, we've moved to a quarterly cycle from this meeting onwards as part of our governance review. Okay. And then the other, if you remember, colleagues, back in January and through to March, we were looking at winter planning 23-24, winter planning and learning. And Lou, it'll soon be time to do winter planning for 24-25. So just invite a report to the September board meeting on that as well, and building on the learning over the last 2 years that the ICB board have been receiving. Thank you. Okay, so I think that is everything on the minutes, the action log, matters arising. Sorry, Rob.
Yeah, thanks, Chair. So just under item 22, in terms of the digital strategy, just to note that Shaukat Ali Khan has been appointed as the new CDIO for West Yorkshire. He has a global role with the Aga Khan University at the moment, and we're really looking forward to welcoming him to the region in August. Part of his initial work will be to look at the existing strategy, talk to colleagues, and then think about what we look at in terms of implementation. So my suggestion would be that we bring that back to the board with that item, because it's to be confirmed in terms of the timings. So that strategy plus his assessment of where we are with it.
Great. Thank you, Rob. That'd be great. And we look forward to welcoming Shaukat as a board attendee to these meetings. Thank you. Okay. So we're going to move on to item 10 now, public questions. Thank you, Dr. Pontis, for submitting a question, which I'm going to hand over to Laura, and we have a response for you.
Thank you. I'll just read out the question, and I'm going to pass to Nancy O'Neill to respond on behalf of Bradford Place. So the question is, with reference to the minutes of the March meeting of the West Yorkshire Integrated Care Board, does the West Yorkshire Association of Cutra's mission to help empower and develop our people to lead services and transform them include the representation of medical associate specialists as physicians and cancer specialists, as we have seen in the Bradford District and Craven Health and Care Partnership recently? Or does the board agree that passing off non-medical staff as highly trained doctors represents a patient safety issue that is not to be condoned? Thank you. I'll pass to Nancy.
Thank you, Laura. The campaign was developed in 2022. We developed it using community insight, as well as the involvement from general practice colleagues, clinical leads within Bradford District and Craven. So the campaign set out to help people understand the range of roles that were available within primary care, working alongside doctors in general practice. So, to shed some light on the vast variety of people working within their general practice surgery. This was on the back of some news in the press, predominantly around the access availability of general practice following COVID, as people were going back to work after COVID. Unfortunately, there were some serious but genuine errors made during the campaign. So we recognise now that despite receiving feedback from one of our clinical leads, that the correct version of the leaflet and posters were produced, but we hadn't updated all the campaign resources. Therefore, the title of Physician Associate had been incorrectly labelled in the versions of some of the posters and animations that were online. Most of the posters had been corrected, but there was a version control error. We'd like to make it explicit that colleagues who were involved in that campaign, who were photographed for the campaign, did not intentionally represent their views. They'd had their photographs used in the campaign in good faith, and the errors were ours. We'd also like to issue a sincere apology to those colleagues whose roles have been mistakenly represented. We're undertaking an internal review to understand in more detail how the mistake happened and to ensure that it doesn't happen again. While every care and effort has been taken through our campaign planning cycles to ensure materials are accurate, on this occasion mistakes were made. We're truly sorry for this, as we know that the overarching campaign and the messaging has been well received by colleagues in primary care and the wider community. We have a fuller statement available on our website, which is bdcpartnership.co.uk. Thank you.
Thank you very much, and we'll make sure, will that link be available, put it into the minutes as well as available online. So thank you very much for the question, Dr. Pontis, and thank you, Nancy, for responding. So we have no other questions from the public. A reminder that there are different ways in which members of the public can get involved in the work of our Health and Care Partnership and NHS West Yorkshire. That includes through our West Yorkshire Voice Forum, our involvement work, as well as through a variety of places and citizens groups and our colleagues at Health Watch as well. And our next meeting in September, we invite questions in relation to that day's agenda, and we ask for them 24 hours in advance, which is very helpful to us in preparing. So thank you. We're going to move on now to item 11, which is our board assurance framework. Laura, this is both information on improving as well as an update. So I'll hand over to you, and colleagues would really welcome your contributions on this.
Thank you. Yes, for those that are using the full board pack, we're on page 71. I will keep giving page references because I appreciate it's a really big pack today, so it can be hard to navigate. So as everyone knows on the board, the Board Assurance Framework, or the BAF as it's better known, is a tool that we use to be able to help us to focus on and to manage the principal risks to achieving our objectives. And we've recently had the findings from an internal audit review of the BAF, which we've shared with executive management team. It's been to committees on the route through to the board, including the audit committee, and then we wanted to share those key findings with you today. There are some real positives in the report. The internal auditors concluded that it does share our key risks. It is consistent with Department of Health guidance around BAFs. It brings together both places and West Yorkshire. It is simple and clear. There's also, we are commended on our decision to try and limit the number of key assurances because that helps us to focus on those controls and assurances rather than having too many. There is also recognition that the work was paused during last year in terms of our board assurance framework with the focus on reviewing our operating model, and that has delayed some of the development that we'd hoped to do over the last 12 months. It concludes that the commitment of board members and senior leaders across the ICB is essential to the BAF fulfilling its purpose and potential, and we are planning a future board development session where we are going to focus on system risk management and the role of the board assurance framework. So over the next few months, we'll also be working on mapping an end-to-end process around the board assurance framework, which will run right from kind of the horizon scanning aspect of it, how we use our risk appetite, and running right the way across our new governance cycle. You will already have started to see some changes today. So we've used the BAF in all of our committees to help set the work plans for the next 12 months. So when we get to item 17 later on, you'll see that those work plans are aiming to do that. You'll also see on the risk register report today that there's an additional recommendation around horizon scanning on risk, and that's a specific prompt to the board to think about that when we're talking about the risk register. The BAF itself has helped inform our board agenda today. So a couple of examples, we did spend time earlier on today talking in informal briefing around health inequalities, and we have planned future sessions around those around different levels of inequalities. And of course, we've got the financial plan on today, which is about how we use our resources and meet our statutory duties. So hopefully you will start to see that it's coming through across the board agenda. There's definitely more to do, and we will continue to work with report authors, for example, to strengthen the links within reports across the meeting to the board assurance framework, and really ask that the board keep it in mind. So we've deliberately put it at the front of the agenda so that it's in your mind as we start to work through the rest of the agenda today. Thank you.
Colleagues, anyone want to comment? Jane, and then we'll go to Becky, and then Fatima.
Yeah, thanks, Cathy, and thanks, Laura. I thought I might just comment as Chair of Audit Committee, because obviously we've seen the report as it came through, and also we have a responsibility around sort of the overall sort of governance and risk management processes within the ICB. So I think as a committee, we welcomed the recommendations from the report. It actually came with a suite of a couple of other audits that have been performed looking at our day-to-day operational risk management processes and the governance framework for the ICB, both of which received significant assurance. So I think, you know, as Laura explained, there were some very good comments and reflections on where we are in terms of the board assurance framework and the rigour in producing it and bringing it together. But I think we acknowledge that there is more that we can do in terms of our maturing as an organisation and using it throughout our committees and governance framework. So I think we were understood and positive in terms of seeing the actions that feel like things that will improve the way that we manage and govern the ICB, and we will keep a clear eye in terms of how we progress on those actions over the next few months. Thank you.
Thank you, Jane. I think that's really helpful. Next week we're 2 years old, so I think your point on maturing as an organisation, as an integrated care board, is really welcomed, as well as the feedback. Becky, and then we'll go to Fatima.
Thanks, Cathy. So at the Quality Committee, we reviewed and we do review all of our risks within the process of every single discussion that we have. But the one we're most worried about, you would be surprised to hear me say, is around children and young people's mental health. So we know that as we came out of COVID, we anticipated there was a huge increase in demand around children and young people's mental health. It was starting before the pandemic. It hasn't gone down. And despite that, and despite all the best efforts of the places at the moment, we're still seeing that as an enormous risk 2 years on. So we've asked for that to be a board review about what are we doing, what are we learning, what's working, what's not working, because at the moment we're not seeing a massive shift in terms of the mitigations that we put in place don't seem to be making a phenomenal difference for our children and young people in West Yorkshire.
Thank you, Becky. And a wider point on the after effects of the pandemic, I think, which then lifts this to more a strategic risk when we're looking at inequalities, for example, rather than it being a corporate risk. Thank you. So we can take that away? Yes, thank you, Laura. Fatima is our board attendee and advisor.
So firstly, happy second birthday for next week. That's flown by, hasn't it? So Laura, I love a good bath, and I think, as you've alluded to, this is a really good, clear, helpful bath, so people are assured that we're focused on the things that matter, because what gets measured gets done, right? I do wonder whether there's an opportunity for us, just being mindful of the EDI improvement plan and the specific ask of us to use the bath, to understand how the lived experience of people and our organisational data is being used to demonstrate positive outcomes in culture. So it'd be great if we could take that as an action to co-create what that looks like. The other bit is an opportunity for us with the development sessions to look at strategically what those metrics might look like. And there's a way for us to do it the West Yorkshire way or the mandated way, and I'm very keen for us to do it the West Yorkshire way. The other bit is also the opportunity of the forthcoming EDI strategy to shape some of this too. So I think this is a very timely conversation, and wondered if there's more we could collaborate on in this space to then influence the wider system as an ICP as well.
Thank you very much. Rob?
Yeah, it was good to see the report and the audit and the additional work to do. And as Jane said, it was good to see the other controls taken at the audit committee getting significant assurance. I was just reflecting on the table in Appendix 1, which gives us the heat map. And I think that as a board, we should be asking ourselves the question, are we focusing enough on the right things? And when you take a quick look at this, you'd probably say yes. And there might be something else to focus on. So if we look at the things that got the highest current score, the environment within which we operate is exacerbating health inequalities, and the actions that we take to address that may not be sufficient. We just talked about that this morning in the sort of briefing session. There's a risk that we'll breach our statutory duties around the resource envelope. Well, we've just been talking about money. I'm sure we'll talk about money a lot today, and there's a huge amount of work going on about it. The infrastructure point, I think, comes out really clearly, doesn't it? So capital, estates, IT, there's a lot of work to do there. Climate change, less so. So there's a risk here that we won't be able to meet the needs of the population due to climate change exacerbating demand. And it may be that we need to do some more work on that one. And I think the one that isn't read, but we can see in the news can have devastating impacts, is threats to our organisation from people who want to do us harm of whatever sort. So currently we've all seen the issues around pathology services in London following a cyber attack. So I always think it's good for us to look at this, think about the controls, now we're talking about the right issues. And I think I've got some assurance that we are focusing on the right sort of big risks and issues, but we might just want to focus on that on the board planning around climate, and we might just want to continue to get assurances around people who want to do us harm in this current context.
That's really helpful for us. And the ask is, you can see then in Appendix 1 that you've then got that breakdown by place, our 5 places, and it's really an encouragement, invitation, requirement to use this as we're having our governance discussions through all our West Yorkshire and place committees going forward, as well as helping with our board planning for this year onwards. Jane, do you want to come back in? Then we'll move to the next item.
Yeah, sorry, I was just going to stress that. So I think, you know, we talk a lot about it here in terms of the direct subcommittees of the board at an ICB level, but I do think there's the place committees ensuring that they absolutely use this in the same way, and it starts to inform the agendas and design. That I think is a really, you know, hopefully a relatively quick thing to change, but I think it will be significant to us as an organisation by doing that. Thanks.
So just to give the board some assurance on that, part of the process for signing off the plans for this year is that myself, Jonathan and Ian and Anthony have met with the place lead and the chair of the place committee to talk through what the priorities are for the year and what people are signing up to, what the risks are. As part of that conversation, we've reinforced that point, Jane, knowing that the audit was likely to come up with that recommendation. And I think, look, you can see the place leads nodding around the table. They've all committed to making sure that that's the case.
Thank you very much. And if I'm going to do a bit of reminiscing today, but back in June 2022 in Leeds, we had a board development session where we agreed that we would all use the same board assurance framework. So we will continue that piece of work. Thank you. Okay. Thank you, Laura, for all the work that's gone on behind the scenes for that. Okay. So our next report is my report as chair. As you know, I share this report each time. It demonstrates the work we're doing across our partnership. It demonstrates our good governance work. I want to highlight with you something that Karen Coleman, if you remember, who has recently just left us from the communications and engagement team, we received high assurance from Audit Yorkshire on our involvement work, and there is more information in the report on that. We've got an outline on our co-production principles, a helpful reminder there for provider collaboratives and place systems. We also note that Becky Mulby, this is your last board meeting with us today after 2 years of being with us as a non-exec member. Thank you so much for all you've contributed to the ICB and your passion and commitment, particularly for citizens and young people. We're really grateful to you. And we are trying to find someone to take on your role and find your successor. And that is live at the moment with a deadline for the 2nd of July. But Becky, thank you so much. And we'll come back to saying thank you again to you later. And also in terms of our succession planning, we've offered 2 placements via the Gaten B. Sanderson Insight programme to give people interested in non-exec roles in the NHS an opportunity to come and find out what it's like with an integrated care board following NHS trust placements. It's also appraisal time and objective setting is taking place at the moment, which began in May time and will conclude into the next few weeks. And we also note that we welcome Therese Patton as Bradford District and Craven Place Accountable Officer following a rotation process, and we thank Mel Pickup for all she's contributed to the ICB and pre-ICB as well. I know, Rob, you thanked her as well. We welcome Therese and also thank Mel for her work and that she will continue within working in partnership in Bradford Place. We also note that our Regional Director, Richard Barker, is retiring at the end of this week. NHS England Regional Director, there are 7 Regional Directors in the country. We're really grateful to Richard for his commitment to tackling health inequalities as well as delivering the bread and butter of NHS England services. And we will very much miss him and thank him for all he's contributed and supported us to do in West Yorkshire. So that's an overview of my report. I hope you find it helpful. Laura and I try and use it to map out some of our well-led work under the Care Quality Commission framework. I don't know if anyone's got any questions or comments at all. No? Okay. Thank you, colleagues. So, Robert, I'm going to hand over to you for the Chief Exec's report, item 13.
Thanks very much, Chair. So the report covers a range of issues. I'd like to start also by thanking Becky for her support and challenge over the last couple of years. I'm sure it's not the last time we'll see you in one of these meetings, maybe sitting somewhere else or asking questions. Look forward to the constructive and positive way in which you approach things. Also like to put on record my thanks to Richard Barker, who's really been instrumental in the way that we work collectively with NHS England and a very strong advocate for system working in the truest sense to reduce the duplication between the regulator, ourselves and providers. You can see in the report that I also reference the pre-election period, the fact that we have industrial action starting this week, the latest round of industrial action from junior doctors. If I look around the table and say that we've got things in place to deal with everything this week, you'll see a lot of nods. we're pretty good at it now in terms of getting in place those arrangements to convene the system and make sure that services will be safe for people who require them. It's unfortunate that we continue to have to do so. You'll note in the paper that the General Practitioners Committee of the BMA is also looking at whether it takes action in the future and what form of action that would be. That will be a risk to everybody in the system if that comes about. We know that general practice is the biggest, after community pharmacy, the biggest single touch point in the system, and our GPs and our teams in primary care have been magnificent over the last few years in dealing with all of the pressure and demands that they face. So if that changes just a small bit, the gearing between general practice and other parts of the system is significant, and the impact will be significant. So, for example, about 18 times more people go to the GP in the daytime than go to an A&E department. So a very small change in general practice leads to a big change in the system. So again, we hope that there won't be industrial action, and we continue to have positive relationships with our local medical committees, our general practitioners and others. I think the rest of the paper people can see as read, and happy really to take any questions or comments.
Thank you, Rob. Just before we do open it up to questions and comments, I wanted to invite Karen just to talk about on behalf of the Community Services Provider Collaborative for West Yorkshire. Karen, would you just reintroduce yourself, please?
So I'm Karen Jackson. I am the sector lead for community services. Rob, thank you for including this in your report for starters. If you remember, we came last year to do an update on community services, and we had a really robust conversation, and from that we developed an action plan which we've been working on. So we continue to work together as a programme across West Yorkshire, and we work really closely with our other provider collaboratives, including the Mental Health Collaborative and Wyatt. We have welcomed Harrogate and District Foundation Trust as a core member of the collaborative, and that's really important because of how patients move and flow around our system and how the interactions work. So that's been incredibly important. We've also been really focused on data. Data collection for community services nationally has historically not been done consistently to the same set of standards and rules. There is a big push this year to drive that from the centre. And we are particularly focused this time around community waiting lists for adults and children. It's part of the NHS plan, and we want to make sure that we meet the objective, but that we're also counting and measuring the same way, and that we can support and help each other to do that. We're also working really hard with our Community Dental Services Collaborative. I think it's important that I explain that's not general dentistry. That's community dental services, and those services support people that have particular needs. They might be mental health needs, learning disability needs, or indeed a physical need that's beyond what can be dealt with in normal general practice dentistry. The team are doing a huge amount of work in that space to design a model that we think will work for West Yorkshire, and we're working with the ICB team to focus on that. We're also involved in a lot of work that's going on across the ICB that's beyond just the immediacy of those pieces of work. So we're working with the UEC and the primary care networks on their blueprints, because we can see that actually community services interacts with all of it, so we're in there. We also, in our work programme, have the oversight for virtual ward. And we know that there's a lot of progress being made in virtual ward, but we're particularly now at the moment focused on our technology supported beds, so we're working hard in that space. We're working with urgent community response, and particularly with the ambulance service, because we want to support different opportunities for ambulance response, and urgent community response, which is the 0 to 2 hour response in somebody's home, is really important. And we're at the moment working on a business case to assess what would happen if we enhanced falls services in that space. So working in that place. We're also involved in the work around integrated neighbourhood teams, around outpatient transformation. We're involved in the work to support the redesign of elective services, particularly those that can be managed through outpatients or in people's own homes. So I think you can see there's an awful lot of places we're involved in, and it's a real credit to everybody in the partnership who comes along to those conversations and drives the agenda forward. And again, thanks, Rob, for including it. I just wanted to make sure you'd got an update.
Great. And that's a really helpful, though brief, I appreciate, 1 year on update for us. So thank you so much. And for anyone, could you just explain what UEC is? I've just make sure we explain.
Sorry, it's the urgent community response. So it's a response to people to try and avoid having to call an ambulance or to admit through A&E. And it's a 0 to 2 hour response in people's own homes.
Great. Thank you. That's really helpful. So, colleagues, do you have any questions on Rob's report or the update from Karen? So I think we've got Hannah, then Becky.
Yeah, it's just a question for Karen, actually. Yeah. And I'm sure it's part of the way that you're working, but just ensuring that the voice of people, communities, families, carers are integral to all the pieces of sort of transformation and change that you describe in there.
It is, and we have representatives from Health Watch engaged with us through the programme, so yeah, it is. We also are representatives on the long-term conditions work, particularly I lead on unpaid carers and personalised care, so we're trying to make sure that voice is heard there too.
Thank you. And that then just enables me to remind everyone about the co-production principles that are sat at the end of my report as well to use. Becky.
Thanks. Thanks, Rob. It's really interesting to read in your report around primary care that we are up 80,000 appointments a month from this time last year in general practice. That's sounds really significant, and yet when you talk to Hannah, the Health Watch experience is very variable about people's access to primary care. So I think the first thing to say is we know we've got variable spend, and we still don't have Carill Formula updated to reflect deprivation or to reflect the range of needs in our communities. So can we do something about trying to remind NHS England that it did commit to doing that, to reviewing that formula, because it hasn't done it. Robust primary care is absolutely critical to our whole system. As we're looking at our challenges this coming year, the financial challenges, Jonathan, you're talking about, we're really struggling to shift the dial to get money into primary care, and I wanted to have a look at that. And secondly, obviously, we are in Ilkley, and I must commend the Ilkley IG medical practice for being totally marvellous the way it offers appointments and access to people. We have to say that because we're on the front door here. But it shows that it's possible if you're in the right conditions with the right support, and we need to learn from that across West Yorkshire. Secondly, Amanda Pritchard at Confed, Rob. And so she talked about a commitment to proactive care for people with long-term needs and helping everyone live well longer. But as you know, we are being required to spend £3,000 per head for people who are struggling with obesity on the semaglutide drug. I've looked at our Ambition 3, and our ambition is showing the rise in childhood obesity in West Yorkshire. The Food Foundation reports obesity up by 1/3 in children. It says in our Ambition 3 metrics dashboard, we're doing great work on people, supporting people with experience in obesity through personalised and compassionate services, that we talk about the descriptor of obesity being driven by poverty. So I want us as a board to be lobbying NHS England about putting as much money into the prevention of obesity, which is entirely preventable, as well as treating it when it hits the point where it's too awful for people. So I want to see the £3,000 a head being spent on people to prevent it as much as people to treat it, Rob. So we need an obesity strategy in this country. We talk about it a lot, and that has to be a joined-up piece of work with education, with the local authorities. We saw in Leeds, when we really focused on it, that you could make it drop. But as all our local authorities are hitting austerity, they're struggling to keep up with that. We know Tier 1, Tier 2 weight management services are under threat. So we can't be sticking plastering problems at vast expense when they get to really critical without dealing with those things that we know how to handle, where there's really good experience in the system. We should be doing that.
Thank you very much, Becky. So we've got a question there on Carill Formula. So before I hand to you, Robert, just remind board members that we hosted a roundtable discussion with NHS England's chair, Richard Meddings, back in February. We had representation across primary care from dental, community pharmacy and general practice. And that was on primary care contract reform. The write-up of that came to our March public board meeting, and that's been shared with the chair of NHS England for him to then share on with other colleagues, but we can follow up on that so we can take the action on that. But Rob, to you, there's Carill Formula and then obesity strategy.
Yeah, so I don't know if Carill wants to talk at all about the work of the Fuller Board and what we're doing for the new blueprint around primary care. As you say, we've got connections back through our representative bodies and through NHS England around what we believe might help with primary care contracting, but it's not in our control. So we do hear what you're saying there, Becky, around making sure that the resources that are played out into the system need to reflect the problem that we're trying to address. So we'll continue to make that case, I think. In terms of the obesity strategy, well, I don't know if Carill wants to say anything about primary care first before I go on to the obesity strategy.
Carill, will you introduce yourself, just to
Hi.
remind everyone?
I'm Carill McKenna. I'm the place lead for Kirklees and I co-chair the Fuller Board with Ian Holmes. It just so happens we met yesterday, actually, and we did have a conversation around the blueprint work. We were able to pick up in that, Becky, some of the conversation that you'd had in the Quality Subcommittee last time, and share the thinking so far on the development of the blueprint with a few other colleagues who haven't been engaged so far. So engagement on that will carry on over the sort of next couple of months, and I'm no doubt we will feed that into the update that we're bringing to the board later in the year. So yeah, it's timely to mention it because we did have that discussion yesterday.
So it sounds like, blueprint sounds like a bit of jargon, doesn't it? So I think we're trying to get to a point where we understand the problems that are affecting practices, communities, an integrated offer for primary community services, and then describing what we're going to do about it, I think is where we are with this. And I believe that we want to be in a position where people working in West Yorkshire feel that they've got representation around decision making and resources being applied appropriately to the problems that we're seeing, and therefore feel like they want to come and work here and they want to stay and work here. That's what we're trying to achieve there. On the obesity front, the third of our 10 big ambitions is to turn the curve on childhood obesity. And that's not something we can do on our own. There are interventions that we can make in the health service, and you talked about some of those earlier, but this is a wider issue. And I think that 10 big ambitions part of the integrated care systems strategy is germane to what you're talking about, Becky. I think that we could take something to the next partnership board to keep reinforcing this as a problem. We know that across the 5 places there have been differential changes in the levels of obesity. Joe and I were talking earlier about the position in Wakefield, for example. So it's definitely something that integrated care systems should and must be involved in. It's one of our 10 big ambitions. And I think we need to keep working with partners at place level and across West Yorkshire if we're going to address it. In terms of whether or not we should be funding certain drugs which we are required to under NICE guidance, I think that is something which is a legal duty of ours. So if we don't want to do that, then I think we need to have a different kind of conversation.
Thank you. That's really helpful. Do any other questions for Rob on his report? No? Okay. Just to note, Laura's let me know that the primary care blueprint is coming to the Transformation Committee. They've got it on their work plan for July, which will then work very well with a full update in September. Going back to Karen's report on community services, something, Karen, we've talked through is about, can we have a version of model hospital for community services? So when we had our meeting with NHS England on the 17th of June to present our system plan, it was something that we put at the end of the meeting as one of our asks to support that sector. Rob, I wondered if you could give us maybe an update and reflections on the operating model for the Integrated Care Board. For anyone who's watching, we spent the previous 12 months in making required 30% cuts, as all integrated care boards in the country had to. That process is now finished. I suppose, my question is, how is that being embedded? How will we understand the effectiveness of it? And I appreciate there are still some pieces of work concluding, which our Remuneration and Nominations Committee were considering last week.
Yeah, I think so the process is concluded, and we shouldn't underestimate the amount of work that goes into doing this properly and doing it in a way which engages the people affected. All of that time is used wisely and cannot be used on things like transformation or financial management and other things. So there is a cost to doing these things as well as a 30% saving. We've concluded all of the HR processes, give or take a small number of people who are still going through at-risk processes, I think, looking to Kate. And we now have an operating model which is which we're using to run the organisation. As we go through that, there will be things that we probably find that don't quite work the way we wanted them to, so we'll continue to make adjustments. I think the biggest single thing from staff, and it's probably something that the board can help with, is given we've got fewer people, how do we prioritise the work to make sure that it's possible to do everything that we're being asked for? So if you look at the requirements from our regulators, if you look at the requirements from ourselves as a board and our priorities, then what you can see is a substantial amount of work that we're being asked to do and we're asking our staff to do. So what they've fed back is please make sure we prioritise as much as possible to make it possible to do the work. I think that's why if you look at the transformation priorities, we've said that there's just 7. We talked about a couple of them just now. So integrated multidisciplinary teams, outpatient transformation, continuing healthcare and so on. And that is a signal that what we want to try and do is put the West Yorkshire work as transformation priorities in a smaller number so that it's possible to actually fulfil and deliver them. So that's it in a nutshell, I think, Cathy. We've made the changes that are required. We've implemented the HR processes. There's a small number of people who are very much still affected. We have had redundancies. We will save the money. There's quite a lot of work to do on prioritisation.
Thank you. I think that's a really helpful update. Thank you to Kate for her work on this, Tim, the early work on that, and everyone around the table who've played a role in supporting that, particularly in places. Thanks. That's a really helpful update that we can track throughout the year. Okay. We'll now move on to item 14, which you can see is in 2 parts. One is our system performance report from Lou and Jonathan, and then the second section around looking at our corporate risk register. And I know some colleagues will come in with a variety of updates as well as an opportunity for board members around the table to ask questions. So Lou and Jonathan, if we go first of all to item 14A, our integrated performance dashboard. Lou, would you give us an overview, and then Jonathan, we'll take some questions.
Certainly. So just to remind you, I'm Lou Auger and I'm the Deputy Director for Planning and Performance, so thanks for having me today. So the paper provides an update of the key NHS performance metrics. It can't encompass everything that we do by any means. It's got the latest published NHS data within it. It also contains this time an update on the ICB's 10 strategic ambitions. And we have also added, on this occasion, an update on the 2023 GP patient survey results. This is really important because we're about to receive the next 2024 release of the data, so it's quite good to refresh our memory of where were we this year. And on the 11th of July, we'll get the latest report for 2024 in terms of primary care survey. So on number 2 in this pack, slide number 2, sorry, on this pack, there are the numbers. So there's basically a summary of the performance numbers. And what I'd like to probably do is bring out a little bit on some of the actions that we're taking, because whilst we can look to see whether we're red, amber or green on a number of these metrics, you probably need to appreciate some of the work that's been undertaken to improve our position. So for urgent and emergency care performance, we have a cluster of metrics. So when I suggest a cluster, I'm on about topics that hang together, such as how long are people waiting in A&E? So there's the 4-hour wait. How long are people waiting on a trolley once they are in A&E? Bed occupancy, delays in discharges from hospital, and also our capacity and uptake and use of the virtual wards. So these metrics hang together quite nicely, and we're currently developing, I know that we've just mentioned the word blueprint for primary care, but we are developing a plan for urgent and emergency care, similar to a blueprint, so that we can get consistency and offer support of the way in which we deliver these services across the whole of West Yorkshire. So if we go back to the end of March, there was an intensive amount of work across all of our trusts that got us to a point where we achieved what was the target at that point of 76% in terms of the 4 hours in A&D. This resulted in a lot of learning. So it's very difficult to get to 76%, particularly when you see how some of the numbers were prior to March. The learning that's come out of it has been taken forward with the West Yorkshire Association of Acute Trusts Urgent and Emergency Care Recovery Group that's meeting weekly. It's a really good group because it's mainly the operational leads from each of the trusts challenging each other very openly and honestly about how they're operating within each of their trusts, learning from each other, and then implementing jointly things that will actually help support the position. So they've been doing thematic analysis of breaches together so they can share their approaches, and they've shared learning from their own individual local improvement plans, which is really helping develop thoughts about what needs to go into the blueprint. We also completed a collaborative piece, and it was quite a deep dive on trolley waits and breaches. So a trolley wait is the time between when a doctor in A&E decides that a patient's condition is serious enough that they need to be admitted to hospital for further treatment and when the patient is actually admitted. So there are lengthy waits in many hospitals, particularly during pressures. And we looked at 3 years' worth of data. We looked at comparisons throughout the year. We looked at what was happening now. And there was an incredible amount of learning that came out of that. And there's been sort of a real focus on the needs of the elderly and balancing risk, both in the acute trusts and the wider system. So again, a series of actions from that and learning that will then help improve and go into the blueprint. And then we're using the learning from these to also help us define our winter review. So we've got a winter planning event, and that's on the 5th of July. So we do this every year, but it's a really good event. It's health and social care. It's all voluntary sector, social services, all the players around the table, independent sector as well. And it is really valuable at understanding what more we can be doing in preparation for next winter. The other thing that you might not realise is that we meet weekly to look at how to improve flow through hospital, particularly focus on discharges. And Karen Jackson, my colleague at the end of the table, is the lead for that group and is helping sort of guide us through it. So it's a really, really enthusiastic group that meets and looks at all aspects. We've been meeting probably for a couple of years now. So some of the things we look at may be things about toolkits that we've developed for carers to help support carers as their beloved members of the family are discharged. We're aligning local policies so that we've got consistency across West Yorkshire, and we're also looking at better utilisation of full services. So those are just some of the examples. Moving through my report, there is a reference to virtual wards and both the access to and the amount of capacity and uptake. And what I really wanted to just note was something here about the data quality. So the data that's in this pack is a published snapshot, so it isn't actually showing the true picture of the utilisation of the services, which is actually a better position than the snapshot that's reported. So I just wanted to mention that. And this point in time for West Yorkshire, our ICB's got the highest virtual ward utilisation rate across the North Eastern Yorkshire region, just to sort of illustrate. I'm sure there's definitely more that we can do. We're currently doing an evaluation of the virtual wards. We've got a number of different agencies involved to help do that independently. So we've got Health Inequalities, Yorkshire and Humber. They've confirmed some capacity to help support the application of the Greener Care at Home Toolkit to understand the environmental sustainability of the virtual ward model in West Yorkshire, and that's been scoped out. The NHS Horizons team were commissioned through NHS England to do some work, so we're working closely with them. And then we've also been looking at some good practice from the South East region, and as a PMO, the group that leads on the virtual wards is also embracing that and looking at how we can sort of copy some of the good practice that's been learnt there. Then I think if I move over to some of the other things, such as the ambulance handovers, whilst we can look at the numbers, I just want to reassure you that there's a lot of hard work underpinning how we're working together, and that's a Yorkshire and Humber approach because the ambulance service is a Yorkshire and Humber service. So we're actually putting together a set of metrics that will focus on a weekly sort of scorecard for this particular service in conjunction with the ambulances, with the Yorkshire Ambulance Service, sorry. And we're looking to see whether or not each of our trusts is able to contribute what we have sort of set as a target in terms of supporting handovers. So we'll be doing that across the whole of Yorkshire and Humber, but with each of the individual trusts that use the Yorkshire Ambulance Service. We're also looking at this on a daily basis, so just to remind ourselves, we've got a system coordination centre that's 24/7. And through that, we can actually watch the ambulances go to each of our trusts. We can see how many are queuing. We work closely with all of our providers to help facilitate, you know, a smooth transition, particularly when in winter it becomes really quite tricky. From that then, I think if I move to some of the other information in the report, looking at electives, so moving away from urgent care, we're working hard still on elective recovery post-pandemic. We still have got some people waiting long times. We are aiming to have no more people waiting sorry, excuse me, I'll start again. We aim to have no one waiting more than 65 weeks for their procedure by the end of September. And I think we've already flagged that we have got a period of industrial action coming up, which will make that even harder and put more pressure on trusts. I'm smiling at Brendan, because I think we're just doing that planning now to make sure that we've got rotas covered. So the industrial action will start this week on the 27th of June. It'll go on until the 2nd of July. The Wyatt Elective Care Recovery Group meets weekly as well. So if you think about it, we've got urgent care meeting weekly and we've got elective recovery meeting weekly. And that's allowing us to do quite a lot of really important collaborative work across the different specialties and pathways within each of the trusts and offer mutual support and capacity across our different providers. The impact of the recovery and also the industrial action will also impact on our cancer waiting times. So we've got a close eye on that. Moving on to diagnostics, without really good diagnostic capacity, we cannot deliver our elective capacity. So we are working very hard on our ability to have no one waiting more than 6 weeks for a diagnostic test. At the moment, we're at 91.8% against a standard of 95%. But I just feel I'd like to put that in perspective. If you look at the ranking across all of our ICBs, we're the second best. So that is really, we're doing well. There's more to do. We've got particular pressures in audiology, DEXA scanning, and echocardiology. We do have the additional resources in our community diagnostic centres, for which we have 5, and they're helping us with additional capacity in those particular tests. For echocardiology, there's also a national shortage of of staff. So some of them take up to 2 years to actually train. So we're looking at how we might have a West Yorkshire-wide bank for staffing of those particular services. And we've got a workforce group that's already set up to do some of that work. In mental health services, moving along, talking therapies is currently not to plan, but performance has started to improve. You'll see that in the numbers. Actions include providing top-up training for therapists, looking at comparative services and best practice, and working on the amount of recruitment and retention and education in place. For the children and young people's mental health services, which I know that Becky's already mentioned, whilst the numbers look good because there's a lot of activity being undertaken, it's the underlying waiting lists that we're struggling on, and we're working really hard on that. We have a series of actions in place. The primary care access survey, which was an addition that we put in with the view that we've got the new results coming through. Just to touch on that, there were just over 122,000 questionnaires sent out in West Yorkshire. We got responses back from nearly 31,000, so that's a 25% response rate. There is a summary of the responses within the pack, and I think what we should be reassured of, because this is sort of quite old now, we've already been working with the results, that each place has looked at this both at practice level and across primary care networks, and have had action plans throughout the year to try and improve the position on a number of the metrics within that pack. Finally, you'll see within the pack the strategic ambitions. So we've got an update on the 10 ambitions that have been set. And what I would like to just mention is the fact that some of the metrics that we have got selected across the 10 ambitions probably aren't refined enough because they don't move very quickly. Some of them have got data that takes 2 years to be reported against. So there is quite a lot of work being undertaken at the moment on a set of supplementary metrics that will help us guide how we're making progress against the 10 ambitions. These were linked to the Joint Forward Plan and also to the ICB secondary prevention transformation work that we've just been focusing on. what we propose is that we work these up over the summer and that we will take them as they become ready and refined to our Finance Investment Performance Committee and to the System Oversight Insurance Group to practice on them, to see if we've got them right. And then we'll be able to bring back a full copy to the board, tried and tested, hopefully in December is what we're aiming for. I've got two other points. One is there is a request in relation to Ambition 6 that's been specifically picked out for ICB board support for further work around the blood culture pathway. And what I'd like to suggest is that we would take that through to the clinical forum and the system quality group for us to do further work on it. And then finally, under Strategic Ambition 9, which is about responding to the global emergency, there's been a detail given on a number of suggested metrics that we'll pick up as part of the review that I've just described that will come back to the board within December. Thank you.
Lou, thank you very much. Very comprehensive overview. And I know there will be colleagues around the table who want to contribute to give greater depth to that as well. So thank you. Jonathan, can I just invite you to give you the finance element of that report? And then Kate, if we could then come to you on the people staffing section of the report. Thanks.
Okay,
Jonathan.
thank you, Chair. So just by way of a reminder, I'm Jonathan Webb, Director of Finance and Deputy Chief Executive. The numbers I'm going to go through now are a bit of a sort of a preview as well of the annual report and accounts that we'll be considering later. So this is the position for 23-24 as a full year. So we finished as an ICB with a surplus of £4.3 million, and that's on our allocation of roughly £5.5 billion. That more than offset a combined aggregated deficit in the 10 NHS providers in West Yorkshire of £4.1 million. So as a system, we ended the year with a surplus of £0.2 million, which, as I say, is a very small amount, and we would consider as a break-even position on our £5.5 billion allocation. We also fully met our national requirements around investing in mental health services, and we also stayed within our agency cap limit set by NHS England, which prescribes a certain amount of money that we would need to retain our spend on agencies with. So not an easy feat to get to a break-even position in 23-24 at all. We have now been in that position for 5 years where we've had a break-even or better position, and we were the only ICS in the north to do so in 23-24, but it was an incredibly tough year with significant financial challenges to get to that point. Thank you, Chair.
I'm just reflecting as you were talking that through that was not an easy task in any way. So thank you to everyone around the table, all colleagues across our places and providers who have come together to do that. It's been a true partnership. And as we talked through last year and we did this year on our planning, that when we make sure that we own it together through peer reviews and these kind of pieces of oversight, then it's a credible plan, and that's what's been proven last financial year. So thank you very much. And I know, as you said, we'll come on to that later when we look at our annual report and accounts. Kate, could I just invite you to, on the people element of the report, and also you can see we've got some overviews, data there on sickness, absence, staff turnover, for example. So I wonder if you could just give us an update in relation to that report.
No, thanks, Cathy. And I think, Lou, you've done a really comprehensive job. The people performance data is quite limited to sickness, absence and turnover. And the good news is, as you can see from the data that we've got, it's all heading in the right direction from that perspective. I think it's important to say that the workforce data is always a bit of a lag. We're looking here at the performance report of December and January. I receive more recent data, but it is still always a few months behind colleagues in finance from that perspective. Were there particular points you wanted me to comment on?
I suppose in relation to the people plan, which I know goes to our partnership board, what are the ways in which we're looking at perhaps retention work or long-term sickness work? I know that you work actively with human resources directors, people directors across our system. So is there anything you wanted to share, particularly from the recent people board? Thanks.
Oh, thank you. I wasn't sure if there was a particular question that had been asked. I've obviously liaised with my colleagues in the provider organisations that they do the hard work in relation to this. I think obviously, as I said, the trends are going in the right direction. I think if I focus on sickness absence first, Some of this is about focus on process. It's as simple as that. So colleagues have described to me, we've done a really renewed focus on things like return to work interviews when colleagues have been off. There are focus around occupational health referrals, and I think particularly around the speed of getting those referrals in and then the response. There were also some good initiatives around local wellbeing champions. I won't name each of our organisations, but one trust has really put an effort in to have lots of local wellbeing champions across the organisation. So per 100 staff, they were describing having somebody who would be in that role, you know, sort of on a voluntary basis, but are able to really direct colleagues from that point of view. So I think there's a number of things, Cathy, but I think it's in relation to just focusing on what are the processes, making sure that colleagues have had access to all the right services and having that identified. Turnover also has going in the right direction. It still sits in January here at 10%. I think obviously we saw it higher than that earlier last year. And again, talking to the HR director colleagues, what are the sorts of things that are happening which seem to be making a difference? Some of this starts with induction and actually making sure that first 12 months, that first 12-month focus is there. One of our organisations describes, you know, that's the time when they're most likely to perhaps lose colleagues who've only just joined, perhaps have never worked within the NHS sectors before. So they actually put quite a number of targeted interventions to make sure people feel at home in the organisation, and then check-ins from that perspective. So quite a lot of activity goes into significant amounts of data. But as each of my chief exec colleagues around the table would say, I know they look in with some scrutiny at their own boards at this level of data. Okay.
Kate, that's really helpful. Thank you. Are there any questions at all on the integrated performance report across the system? Fatima, then Becky, and then Tom.
Thanks, Chair. So firstly, thank you for a really comprehensive report. I think one of the things I always try and bear in mind, Lou, when I look at this report is if a member of the public was looking at it, what would they interpret? And I think it's really important to acknowledge what Rob just alluded to in his previous report, which is we have less resources than we've ever had before, and our people are working harder than they ever have done with less. But despite that, we're making really good progress in a number of areas, and I think it's really important that we acknowledge that and to say thank you. But having said that, there are still lots and lots of people waiting to access care, and I'm really assured with the detail within the report of what is being done to support those individuals. But I wonder whether there's an opportunity, thinking of the discussion we had this morning through the lens of health inequalities, where we could target some disproportionate resource in some of those areas, because we know from our conversations with the public and the reports that Hannah particularly works on that some people are particularly struggling, and that is having a massive, possibly disproportionate impact on their day-to-day lives. So I wondered if that's an option. The second bit is recognising that despite everything I've just said, patient expectation and satisfaction are at odds with each other. So the expectations are higher than ever and the satisfaction is lesser than it has been before. So how do we articulate some of the messages that this report alludes to? Because there's so much in there of what we are delivering that I think it's important that our public know that we're doing our best despite some really challenging circumstances, and that people may still have to manage their expectations when it comes to accessing care and support despite the best efforts of our staff, because what we know is our staff in the front line in our acute trusts receive the adverse end of that impact with the patients that they come into contact with. I suppose my final bit is really thinking how innovatively we can prepare for winter. So it's really great that we're preparing for winter now. How do we have conversations with stakeholders we don't normally speak to about winter? Because the thing is, if you try and redo something with the same stakeholders, you kind of come up with a very similar product that you've had previously. And I think sometimes what we've learned is we do need to think creatively and differently. So are there people that we haven't invited before that we could engage in that process? And then the final bit that I really wanted to think about, and we've already started this conversation, haven't we, is the metrics of this is a document that articulates the experience of a number of people that are already in the system. How do we know whether we're reaching the people that need it the most? And there's an element, I think, of work that we're undertaking to reflect that, but I think it's important to acknowledge that this is just one element of that bigger picture.
Fatima, thank you. That's really, really very helpful. Lou, I'm just going to take some of the comments and then invite you to come back, and Jonathan as well, if there's anything on finance. Becky, then Tom.
Thanks. And just to say that the Quality Committee is taking the metrics on infection rates. So we reviewed them at the last time, and we're getting a report back at the next Quality Committee to see whether what's going on there. Is it just about antibiotic prescribing? What's happening here? We've got an increase in some places around C. difficile, a general overall increase in infection rates. It's trying to understand what that's about and why. So that's the first thing. Quality Committee is doing that. It's good to see Leeds and Bradford are reducing your waiting times. Hey. Thank you. Primary care. I love this. Thank goodness we've got trends around satisfaction. I know it's already out of date because it's coming in July. I think it'd be really helpful at your September board when you've got the July ones to see. But I think also just pointing out and pulling out the ones that really matter in here. So the one that really, really matters is that were my needs met at my last appointment? And when you look at that across the board, yes, apart from Bradford. And Calderdale. So what's going on there? Has that improved this time? Are we going to see an improvement? Because we should. Now, we can, and then trying to understand why. We had quite a good conversation at the previous board about what was going on in each place, about what was happening. But as you know, it's going to be differential between general practice. It's going to be differential in Bradford between central Bradford and out here. So understanding how much of it is really poverty related, is really about locum access, is really about funding. We know that our poorer practices get less funding than our wealthier, the practices of wealthier communities. How much of it is about that and how much of it is about how well it's organised, etc. And the differential between those two, so we don't hide behind some of those very difficult issues, but we're really onto it. So how that's being handled, not just within the blueprint, but that variation between would be really helpful. And the overall experience of general practice, ease of appointments, important, but it's whether people's needs are met and how they experience it that really matter. So are they getting their needs met? And if you look at that in relation to your question, slide 41, question 18, one thing we can see from that is that not getting an appointment in general practice is not ramming our A&Es. Despite all the myth and rumours, it absolutely isn't, except, of course, out of hours when general practice is shut. So when general practice is open, it is doing its best to meet needs, and people aren't then rushing to A&E, which is a sort of unhelpful myth. So it's good to know that and to see that here. We've known that for some time. A&E is busy because people have got complex needs and our population is sicker. However, it says we've got sort of around the last 2 years, 34% of people who, if they don't get an appointment, are not going anywhere, and I worry about those people. We struggle to know where they are, we struggle to know who they are. I think the work that we heard from Bradford this morning, from Bill about street-level folks knocking on doors, checking in on people, seeing how they are, is one way of finding those folks. But that, for me, is a slight miscorrelation in that we won't have that data on them here. It won't be featured in the patient satisfaction. So maybe in the September report, it's looking at those trends. It's making sure how we're meeting needs, what's the rationale where we are and aren't, but it's not as much by subsets of place, and then what's happening to people who don't get through and where are they going.
Great.
Thanks.
Okay, thank you. And just to record something we agreed at our board development session this morning on inequalities is, Lou, you've offered to do a mapping exercise against those metrics so we can get a much more rounded view. Lou, would you respond to Fatima and Becky's points? And I wonder, colleagues in Calderdale, Neil, and in Bradford, Nancy, whether you might want to respond on the primary care query that Becky's just had there. But Lou, first of all to you.
So I'll always take a break from you, Becky. I'm really pleased that we've got the right information in the report, because it does stimulate a lot. It really is a good set of information to have. The access group, primary care access group, I think is probably where we need to look at the figures from this report and the next one, as well as obviously there'll be a lot of local interrogation of the data, and what we're going to do is put the pack in a much more easy to use set of data for all of us, so that we can look at not only our own, but we can also look at the rest of the country to do some really good sort of assessment of where we sit. So I'll make sure that we do a really good job on that in your absence, but we'll take that forward. Thank you for the... Oh, I'm so sorry. I just need to... Okay, thank you. Rookie error. Quality Committee, thank you. We noted that item's on the agenda. That's really helpful. Then going back to Fatima, I think with the winter event, we have actually shared it, we think we've shared it really widely. We've asked for local places to decide who needs to come. But what might be a good idea is to pull out who's responded to say they would like to come and just run it across colleagues to see if there's anybody missing. So if that's a good approach, we'll do that. That's not a problem. and then take your point about articulating messages around doing more with less and working really hard on it. And then in terms of the disproportionate resource, I think that's quite a big topic, and I think we'll have to pick that up away from this meeting, because we need to be specific. What are we actually targeting? And I think we need to understand better what the disproportionate access is for certain services before we can sort of look at addressing that.
And just a reminder on the role of West Yorkshire Voice. Members of West Yorkshire Voice are there to help us and support us as an ICB, so they may also be a source of critical friendship to us. Nancy and Neil, just... Welcome to the second part of NHS West Yorkshire's Integrated Care Board meeting here in Ilkley today. We are operating our meeting during the pre-election period, and all items on the agenda today are considered business as usual. We had to pause our meeting then due to an issue with our microphones, but they are back on now. We have received feedback that we need to make sure that the audio is clearer, and we will aim to do that for the rest of this meeting. We were just finishing up on our integrated performance dashboard, and thank you to colleagues who presented that, including Lou and to Jonathan, and for comments we had earlier. I wanted to invite colleagues working with the Cancer Alliance or in the Cancer Alliance just to provide an update, particularly in relation to the metrics that we've had reported on today. So Brendan, could I come to you first? Would you introduce yourself, and then Neil?
Hello, I'm still Brendan Brown, the acute sector lead. Thank you, Lou. That was a great report. I think to the conversation that you led, it speaks to our improving performance, which compared to the national picture is consistently good. We know where our challenged areas are, and I think, as Lou described it, it demonstrates a collegiate way of working across all sectors that speaks to not hitting the target just to miss the point. At the end of all of these metrics are patients and their families who are going through difficult times. So I think to Cathy's example, this speaks to how the West Yorkshire Association of Acute Trusts works with the Cancer Alliance on that improvement journey, but I'd argue it also speaks to the work, as Karen has described, with the Yorkshire Ambulance Service, but also to the conversation Wyatt had recently with Hannah and her team from Health Watch about, whilst we may be improving on trajectories, we need to do that not just at our pace, but also at the pace of patients and their families. Neil, I don't know if there was anything you wanted to say.
Nothing, thanks, Brendan. I think that summarises it nicely. I think the priorities have been identified in the annual plan for the West Yorkshire Cancer Alliance, and obviously a priority for the SDF money that's coming through as well.
Thanks for that update. Tom, did you want to come in on this report? Would you introduce yourself, just to remind everyone?
Yeah, I'm Tom Redden. I'm the Chief Executive of Leeds City Council, representing the local authority. It was just actually a question that was from the last... the performance report paper, if that's okay, Chair. Yeah, no, it was just a comment and a question. Sorry. So the comment, really good comprehensive report. I was thinking of our system locally and what's making the biggest difference at the moment, and the Home First programme that we've got is actually been really successful in cutting across quite a lot of the different categories, if you like, of helping the hospital trust, helping the care system, helping more generally patient satisfaction, etc. And whether there's a way of picking up almost the story behind the numbers sometimes of things like that that are making a big difference. So it was just a suggestion really for the future rather than asking for a comment. But I think that would be helpful, because there's a danger we get a bit siloed in our assessment of performance sometimes. And actually it's the whole system work that we do that often makes the biggest difference. So there'll be I'm sure other interventions like that in maybe other places that act in the same way. And then the question was just around whether we measure, I might have missed it, but cancellations of electives in particular, and just thinking about the way that the impact that has on families and individuals, and also the economy and running public services, is quite significant. So sometimes, obviously, the time it takes to have your operation is the most important thing, obviously particularly with the most severe cases and the life-threatening positions. But a lot of the electives that we do are more about you know, are as much about things that actually can wait, but you need to know when it's going to be because you plan your whole life around it. And so I'm interested just in, do we measure that, and you know, if not, could we?
Thank you. And that whole point on waiting well, which we have followed throughout the partnership. Lou, would you respond on that? And thank you, Tom.
Yes, I'll pull out some data, Tom, because... Oh. And shout. Okay, is that any better? Yes, I've got it right this time. Brendan, I think you're just putting your thumb up to offer something, but yes, there is data available. Yes, we can provide it. I don't know what you wanted to add.
Well, I think we talked about this in the March meeting, that we do monitor this because it speaks to the health inequalities piece. And what we're focusing on is there a frequency of I think I referred to them as, referred to these cancellations as DNAs. And I think your colleague called out that doesn't sit well, but it was an easy language. But actually it suggested a level of blame, actually, and do not attend. But it's a language that people understand, so that is monitored in each organisation and will be available through PLACE data. But I think it speaks to the whole health inequalities piece and what this means and what the impact of this means for people. It's not just that, I think probably to Tom's point, it isn't just the person undergoing the procedure that it has the impact on. It's the wider impact for folks. So it is something that we regularly look at.
And I think there's also a few metrics on how quickly then they get rebooked. I think there'll be something about the industrial action specifically as well. So there's a number of things that we could look at in that area, and we'd also look at some case studies. I'm sure that people have got quite a few good stories, but if we perhaps put them around particular metrics so that they're very relevant to a number rather than, you know, having something that doesn't sort of relate back.
Okay, thank you for those responses. Hannah?
Yeah, just a couple of points. Just on the, we've mentioned it before in meetings, but we're just working with the ICB Insight and Involvement team around developing the idea around a people's risk register as well, around really bringing that voice of people's experiences to sit alongside this performance dashboard. I just wanted to go back around the point around expectations of people. When we speak to people, actually, the majority of people are really understanding of where services are, actually, and actually some of the frustration comes from introducing new systems that maybe don't work or an additional barrier to accessing care. So I think just to highlight that. And then leading on to that, we're hearing an increasing trend of people saying that they are just giving up. And that goes back to what Becky said earlier. So I think we could possibly do as a local health watch some insight work to support that, maybe for future meetings.
And thank you for that offer, that's helpful. And we know, Tom, you're talking there about Leeds Home First as well. There are similar versions of that, but we need to make sure, a point that came out from our board development session this morning about that exchange of best practice and experience and learning and evaluation, which is important as well. Thank you. Bev, I wanted to invite you just to give us an update on maternity services, which is coming up in the report on the corporate risk register. But before I do, Laura, would you just give us an overview of the corporate risk register? Thank you.
Thanks. Yes, I'll just do a brief introduction and some pointers to where might be helpful to look at within the report. So this is the first risk cycle of the year, and the report sets out the corporate risks for you. It also includes the high-level place risks and place risks that are common to more than one place. On the corporate register, overall, we have 50 risks on there, and they're set out within the report. They have all been reviewed by executive management team, and then they've been to quality committee and finance, investment and performance committee. As I said in the introduction, I'll just point to a number of aspects within the report that you might want to discuss further. I draw your attention to the 7 new risks that are set out within there, all of which have been discussed in detail by committees en route through to the board. You'll note that 2 of those are at a critical level. One relates to the potential of a future pandemic, and through the discussions in committees, we've agreed that we think that that ought to be moved on to the board assurance framework as a potential long-term risk, rather than an immediate risk at this moment. So we are going to work on that during the next risk cycle. And the other one that's at critical level is around the financial break-even. That replaces the previous year's risk, and we'll be covering that later, I think, during the financial plan update. I particularly flag paragraphs 5 and 6, where we've done a summary for you of the discussions that took place both at executive management team but also at either of the committees. Hopefully that gives you some insight into the additional assurance that was given through those discussions. I've also shared the findings this time from the internal audit review of risk management. So this sat alongside the board assurance framework internal audit that I spoke about earlier on in the meeting. This one receives significant assurance and confirms that we have a robust risk management framework in place with effective deployment across the ICB. There are a number of areas for development and work that we need to do over the next few months. We need to be mindful of our risk appetite, and obviously I mentioned that earlier. We should be talking about that. It should be informing our discussions. There's some work to do with risk owners around making sure that there's a clear narrative when risk scores are changing. So it's not always immediately obvious why a score has gone up or down, and it's important that you can see that as you look at the risk register. And there's some further work to do around understanding the differing risk profiles across the 5 places. And that's a point that Audit Committee have been spending some time focusing on. So the final thing I was just going to say was that you'll remember me saying earlier in the Board Assurance Framework item about horizon scanning. There is a specific prompt in this report about are there emerging risks that we need to be mindful of as we go into the new risk cycle to make sure that we're capturing those onto the risk register. Thank you.
So I know on the risk register, one point is around maternity services, and I also wonder, Sarah, if you want to talk about NHS 111. So hand over. Bev, would you introduce yourself just to remind people who you are? Then we'll go to Sarah.
Well, thanks, Chair. My name is Bev Laguerre. I'm Director of Nursing for West Yorkshire ICB, and in respect of this item, I am the LNMS SRO and Chair of the Local Midwifery and Neonatal System. So the people will notice that we've had a long-standing risk on the corporate risk register, which is risk 2102. That scored really high. I mean, it was still high recently. It scored 16, the last iteration. That's now closed. Members of the board will know that we've had a significant push on recruitment of midwives in particular into the provider organisations, and we've done that at West Yorkshire level to really, really good effect, and therefore that risk is now closed. However, there's a consequence to that. We've got a significant amount of new registrants and new staff within our services, and that means we've got a new risk, which is risk 2436, and that's not just around sickness and absence, because we've talked about that again at this board, but there is a significant element, probably more so for workforce in maternity services, around training. So we've got a risk that scores at 12, as I've said, 2436, which is around sickness, absence and training. There's also another maternity risk around, that's 2427, that's around the LNMS not being able to deliver their ambitions. That was due to absence in the core LMNS team. And board members will remember that we had a significant and really detailed presentation at previous board around the work of the LNMS. I'm pleased to report that I think that we'll be able to reduce that in the next cycle. We've got approval from the board, the LNMS board, to appoint to an MVP lead, which will help co-design services with service users across the system. We've also increased hours locally in Bradford and in Airedale for our MVP leads, and we have interviews on Thursday for a Director of Midwifery for the system. Thank you.
It's a really helpful update, and Bev, thank you. Over the time we've been meeting as a board, you've given us verbal updates, and we also, if anyone's interested further in maternity services across the system, they can go back to your report of March this year as well and have a look at that online. Sarah, would you introduce yourself and inviting you to talk about 111 services for mental health?
Yeah, Sarah Munro, Sector Lead for Mental Health, Learning Disability and Autism and Chief Executive Lead in York Partnership Trust. We put the NHS 111 service provision on the risk register because it was unknown in terms of the scale of the demand that the service was going to see. There are 2 elements which we're keeping a close eye on. So we've got the first full month data for May. So our call handler, where calls get diverted to via 111, is commissioned to receive just short of 3,000 calls a month. In the month of May, it received 7,000 calls, and approximately over 2,000 of those were diverts from NHS 111. So there's more that we need to understand in terms of, is that still the right demand going to the right place? Because it is such a significant shift. And making sure then that people are ending up at the right place, because what we don't want is people dropping out of the calls. There is another element that's emerged, which we were mindful of, that we've had some feedback, because the when you ring 111, it's a standardised messaging system that follows you through in terms of the options. We've had some feedback and we agree with it, is the way in which the language that's used, whether you're particularly distressed or if you've got neurodiversity, it can be hard to follow. So we've raised that with the national team to see what's the process of feedback and refining what that message is. Especially when you've done things like your Oliver McGowan training, you understand the importance of reasonable adjustments up front, which can make it easier for everyone. So there's two elements. So there's nothing for the board to do other than be cited at the moment, because we'll take it through our programme board. But if we're concerned that risks continue that we can't mitigate or manage, then I'll bring it back to the next board meeting.
Thank you, Sarah. It's really comprehensive, very helpful. Okay. Rob, did you want to come back in before we finish up on this section?
Yeah, it's helpful to see the correlation between the finance performance papers and the risk register, and also to draw it back into some of the conversation we've been having, I think. So Sarah's points there around neurodiversity and language and reasonable adjustments in primary care. You can see some of that reflected in the patient survey results that we saw earlier, with poorer satisfaction rates for people who are neurodivergent, for example. And I think we should always keep triangulating some of this data. Just to draw us back into that primary care information that we had earlier, in terms of the absolutes, I think looking at the slide 40 with the summary of the survey, I think Becky was right to draw out some differences in different places. But I'm also interested in the absolutes, you know, what proportion of people are satisfied with things. And given the conversation we've had earlier about roles, I thought it was really important to recognise that if you look at the proportion of people who had confidence and trust in the healthcare professional they saw, you know, in Bradford it was 91%, in Caldale 92%, Kirklees 94%, Leeds 94%, and Wakefield 95%, I think. So the kind of people that people are seeing, but less than half the time is GP, the rest of the time it's somebody else, is relatively strong. Similarly, the proportion of people who feel their needs were met at the last general practice appointment, you know, 90%, 90%, 92%, 92%, 91%. But I think the figure quoted earlier by Becky was about experience in general practice overall is lower than that. So people's overall experience, which is really driven by the access elements, it looks like from the data, with Bradford being, you know, not as good as the others. Now, to Tom's point about what's this telling us, what's the narrative, I think if you look at that in particular, that work, you can see that Wakefield, Leeds and Kirklees tend to be better than the average, the national average. And there'll be variation in that, but they tend to be better, and they're getting better. So the results have got better, and they're better than the average. Bradford tend to be worse than the average, but for many of the indicators, they're getting better. And Calderdale tends to be worse than the average, and actually tends to be getting slightly worse. So I think when this comes back next time, I know there's a huge amount of work that's gone on in Calderdale since 2023. There's all of the work that's gone on around universal healthcare in Bradford and various other bits that's happened. What I would hope is that we'll see a shift in that. But those core elements, which is why we support primary care and general practice so much, that thing about trust and meeting needs when we get through the door is relatively strong still. So I think we really do need to look at that story, that narrative, and where we're focusing our efforts to make the improvements.
Rob, thank you. And then, as we'll recall, we're having a blueprint for primary care going through our governance processes from the Fuller Delivery Board that works across West Yorkshire. And we'll have a report in September to bring this back as an update. Okay. Jane, did you want to come in on that point? And then we'll move on to item 15.
Yeah, sorry, it was just on something specific within the risk report. So and also thanks to the commentary that's been added. I think it's been fleshed out a bit more in terms of the discussions from the exec committee management meeting as well as the subcommittees. So that's really helpful. I did notice on the quality committee had drawn out there's a comment around the risks around neurodiversity, children and young people. that are static risks, very highly rated, etc. And in the commentary in the report, it says about suggesting that the risk appetite around this risk should be further considered. And it wasn't clear to me quite exactly, they look like sticky, significant risks, and I wasn't quite sure how that was intended to help us understand what's going on.
So I think, Jane, I talked about this in the BAF, which is I think we need a review because when you look at the mitigations, it says we're not coherent in our risk appetite and our approach to neurodiversity across places, and also that some of the things that we put in place don't seem to be really shifting the dial. So that's what I said in the BAF, that's what I meant in this one. And you'll see also in our quality committee, we've also asked for domestic abuse to be considered as it seems to be a national issue. We're seeing it all over the place that there is a real rise. I don't know what that's about. It's concerning. I don't know whether you're seeing it in local government, Tom, but we're definitely seeing it in our front door of the NHS, both in A&E and in primary care. So also to see whether that needs to go on the risk register.
Thank you. Rob, would you talk about the summits that we've run recently? We shared this with the NHS England national team last week as well.
I think you can see from the annual report and elsewhere, and we've discussed here, that we've had summits into neurodiversity and what we might do around changing the system. Just to reflect that in our sign-off meeting for the annual plan with NHS England, we talked about this issue. I think we talked about I talked about three categories of things that we're dealing with in the ICB and in our system. One is where we're not performing as well as we should be and we need to improve. One is where the targets look good, we're performing quite well, but there's a missing population. And we talked about, talked about this perinatal mental health, IAP services, etc. And then there's a group of things which we might not be able to deliver unless we radically reform the system. And we said ASD, ADHD, neurodiversity is one of those things, and we were asking them to help with that. Now, there is some national work going on which we've been invited to be part of, to consider how do we meet the needs of neurodiverse people, and how do we make sure that the diagnosis process and the assessment process is changed. So that feels like a step on, because that's definitely in that basket.
Jane, but you'd also like some greater clarity in that section. Yeah, noted. Okay, thank you. All right, I'm going to move us on now to the next section of our meeting, where we'll be looking at a series of annual reports, looking at our accounts, committee terms of reference, risk management policy. So we have a section now where we'll be noting or approving a series of documents, and particularly hearing from colleagues on the annual report and accounts for 23-24. We'll then have a section on finance and capital, and then a point on committee AAA reports from across our governance committees. So, annual reports, Jane, from our committees, they're coming here for assurance. They've been here for the board's review. Is there anything you'd like to share?
So we, the audit committee has a role to review the performance of the committees. So we've reviewed the papers as well as them coming here. So it's pleasing to see that all the committees have fulfilled their terms of reference through the year. Lots of good work been going on. I think the one committee that I think we've talked about previously, either in development sessions or publicly, in terms of the further development of the Transformation Committee, and I think that's nicely drawn out in the report. So I think it'd be really interesting to see how that does evolve over the next year in terms of supporting the work of the ICB. We, as the Audit Committee, then do our annual report, and that one has to come to the board for approval, whereas we've reviewed and recommended the other ones coming through. So I'm happy to take any questions in the spirit of time pressure on the agenda, but we similarly have fulfilled our terms of reference for the year. Thanks.
Great, thank you, Jane. And we note for each committee there is an area of development, so there's always a room for improvement. And I think in reflecting that we're only 2 years old as a statutory body, though we're all drawing on good past experience and track record in other work, has been really helpful. But I think there's as the appraisal season is on at the moment, that is something for each committee chair to take forward with their executive lead for the full membership of the committee. Does anyone have any questions at all on those annual reports? Thank you to everyone who contributed. to support them? No. Okay. I think there's something, Jane, about the risks and how we talked earlier about taking the BAF and how making sure committee work connects to the BAF, and also how risks connect between places and West Yorkshire. I don't know if you want to come back on that before we move to the next item.
I think one of the development areas that I guess Audit Committee see themselves as playing a role to lead on is ensuring that we are working together between FIPSI, Finance Investment Performance Committee, Quality Committee, the Audit Committee, and ensuring that we are sort of reviewing at the appropriate place the various risks or audit reports coming forward, but in order to make sure that we've got a rich discussion and that any recommendations are picked up appropriately. I think we're also trying to make sure the work plans for each of those subcommittees is planned out in a way that makes sense in terms of sequencing of discussion. We're keen that the most directly relevant subcommittee has the in-depth discussion first, and then it may similarly still come forward for Audit Committee to have a review it. But I think the dialogue, conversation between the chairs of those committees will just enhance sort of our review of that over future years.
And I know you've already suggested this and agreed to it, but we can note it as an action today for you to meet with the committee chairs of our West Yorkshire committees, and also your offer to place committee chairs as well, just to have that overview on work plans for this financial year. Great, thank you. Don't go anywhere, Jane. We need you for a few more items. So thank you for that. We've now got item 16, which is our annual report and accounts. I'm going to first of all hand over to Rob just to, I suppose, give an overview of the year. Then to Jonathan as our Director of Finance, and then Jane as Audit Chair. Thank you to everyone who's been involved in putting this together. It's been a huge piece of work and also celebrates a number of things, including what Jonathan shared with us earlier about our system financial delivery in 23-24. Rob, to you.
Yeah, similarly, so with the pressures of time, I'd just make a few very short points. So throughout the year, I think the Integrated Care Board as an organisation has played a full role in the system. So we are an organisation with an integrated care system that's been around since 2016, and we continue to work well with our partners. We've done that in a period of extreme stress and pressure, I would say, on the system, brought about by a combination of external factors, including cost of living, as we all know, increasing demand for services, the impact of industrial action, and the fact we've had to spend management time mitigating that, changes to the structure of the Integrated Care Board during that period, as well as changes to some of the other organisations within the system. Despite all of those things, and the significant financial distress and pressure that's been in the system, I would suggest very strongly it was a successful year. And we've heard from Jonathan around our financial performance on a number of fronts, breaking even, managing our targets around things like agency expenditure and capital and so on, meeting most of the targets set by regulators and delivering on our trajectories, and at the same time staying true to our local priorities around health inequalities. That puts us in a good place for the future, I think, because it's not going to get any easier to deliver in our system, and we've heard from local government colleagues about the pressure that they face as key partners. We've signed off our plans for this year, which are stretching and challenging, and we've got a medium-term set of financial plans, which again look like they require some significant transformation to take place. But as I said in the report, I think the work that we've done together gives us the best possible chance of continuing to make progress, which is, I think, a medium-term game.
Thank you very much. To you, Jonathan.
Thank you, Chair. So I'll just do the formal bit now before I hand to Jane. So we do have a statutory duty to produce and publish a single document that contains our annual report and accounts. And it contains the activities for the previous year in a format and content that's directed by NHS England. It's made up of three things: the performance report, the accountability report, and the annual accounts. In terms of the timetable we followed, we agreed the overall timetable at the Audit Committee on the 22nd of March, and all members of the board were invited to comment on the annual report on the 10th of May. We had a walkthrough on the 24th of May with the Chair and the members of the Audit Committee of both the annual report and the annual accounts. And then the most recent formal meeting of the Audit Committee happened on the 19th of June. That Audit Committee, as usual, had the ICB's external and internal auditors present, and the Chair and the Chief Exec were also in attendance and shared their reflections. I'm happy to say that the Head of Internal Audit opinion for 23-24 was significant, which is positive. And we got an unqualified and unmodified audit opinion from KPMG as our external auditors. And as such, the Audit Committee were happy to recommend approval to the Board. I would draw the Board's attention to, and I think, Laura, you probably want me to do this, the actual statement. So, yeah, I thought you would. So in... If we, as a board, make the approval today to sign off the report and accounts, if you just bear with me, each individual who is a member of the board at the time the report is approved confirms that, firstly, so far as you are aware, there is no relevant audit information of which the ICB auditors is unaware that will be relevant for the purposes of their audit report. And secondly, that you have taken all the steps that you ought to have taken in order to make yourself aware of any relevant audit information and to establish that the ICB auditors is aware of it. So basically, if there's anything that you know that you think the auditors need to know, tell them or say now. Okay. Thank you, Chair.
Okay. Thank you very much. Jane, as our Audit Chair.
Yeah, I don't want to repeat everything, but as Jonathan's covered, the number of audit committee meetings we've had in the last couple of months and the reviews that we've done through those meetings. So as an audit committee, we've seen several times drafting of the Head of Internal Audit's opinion and the reports that have come through the internal audit work, some of which have been highlighted and mentioned along the way, but really pleasing that they've given us significant assurance. And in terms of external audit as well, we received the report from the external auditors at our last meeting, and we're really pleased. You know, for a complex, significant scale of organisation that we are, to receive the unqualified opinion, but particularly to have so few either corrected or not corrected adjustments is an incredible testament to the work of the teams throughout the organisation in finance, but beyond finance as well. So, you know, that people shouldn't underestimate how challenging that is to deliver on. So our thanks to those. We have also appended here a summary of the external auditor report, annual report, which captures, you know, some of their reflections, also in complement to the internal audit work around how we govern ourselves, how the risk and assurance frameworks work, the value for money work that they've done, the challenges around efficiencies, how we've hit our financial targets. So hopefully that's a bit more of a user-friendly version than the sort of more detailed audit report that we've reviewed at the Audit Committee, and for sure with some of those themes that we've discussed today and will continue to be themes for us as a board as we seek to, you know, on our journey of continuous improvement and maturity. Then I think there's some quite useful you know, comments and reflections in there that I think it would be good for colleagues to have a look at. And as I say, I think it's pretty user-friendly compared to some of the elements. We also were happy to recommend the board approving the report and accounts, and also the representation letter that Jonathan just mentioned, thankfully, since nobody's made any further declarations at this stage. So thank you.
So, colleagues, we're asked to approve the ICB's annual report and accounts for April 23 to March 24. Are we happy to do that? Great. Nods around the table. And we're recommended for us as a board to approve the signing of the management representation letter on its behalf by the accountable officer. Are we happy to do that? Yes, great. Thank you very much. And in looking ahead to our September board, that will be when we have our annual general meeting, and we will create a public friendly, brief version of this document that we can then share out as well, though we have done this as required. Rob?
Yeah, I think we need to do that, and we need to, I think, reflect, I think, as Brendan said earlier, this report is all about people and the people who've benefited from the services that we provide the people that we supported at the beginning of life, the people supported at end of life, and all points in between in every community across West Yorkshire. And we mustn't lose sight of that. We mustn't lose sight, as we've been discussing, of where we really need to do better. But I really genuinely think we should be saying thank you to all of the partners that we have and to all of the staff. To recognise, for example, in the finance team, who've been through a major reorganisation and a reduction, and in the governance team who've been through a major reorganisation and reduction. We've got a set of clean accounts, we've got an unmodified opinion, we've got significant assurance, and we've got a finance team that's just been accredited for future focused finance, which is all about quality and people. So that seems to me to epitomise the kind of ambition that we've got as an organisation for the people that we serve and the staff that we employ. So we mustn't just see this as a dry academic exercise, I think. The rules and the relationships that we have will determine how successful we are, and this sort of demonstrates that we are being successful in really quite difficult times.
Thank you, Rob. That's really, really helpful. There's always areas of development which we've talked about as well, and what we can see already today is any recommendations coming through from the audit are starting to be embedded, for example, in our reporting around the integrated performance dashboard, which is really pleasing that we're acting so quickly. Okay, so thank you for everyone involved in that, including Jonathan and his team. Much, much appreciated. Okay, so we have that approved, and that will be submitted, Jonathan, soon as possible. Tomorrow. Okay, we note that. Thank you. All right. We're going to move now on to item 17. So another item where we're looking for approval, as is the next one. So these are our committee terms of reference and work plans. Laura, we have them here for all our committees at West Yorkshire and Place level. Would you just give us an overview?
Yes, certainly. So this is the forward-looking bit of this suite of agenda items. Each of the board's 10 committees, as part of their end-of-year reviews, have reviewed their terms of reference, and you have them appended here with the amendments that they would like to make, as well as the work plan for the year. Work plans do develop as the year goes on, but these are setting out the ambitions at this point in the year, so that we're asking for board approval, please, for both the amendments to the terms of reference and the proposed work plans for the year ahead.
Okay.
I can do, yes. So anyone who has been sat in one of the 10 committees, whether that's one of our 5 place committees or the 5 West Yorkshire committees, have all been asked to undertake end-of-year self-assessments. So we do surveys. The findings from that are then looked at in detail and are discussed in each of those committees. They help to drive the detail that's in the annual reports that we talked about in the last 2 items, and then they also help to inform what we want to do over the next 12 months, and particularly those areas for development that we talked about 2 items ago are built into the work plans really going forward. So everybody's involved. It is very much a full governance review at the end of each year.
Colleagues, are you happy to approve those? So first of all, the committee terms of reference for all those committees mentioned, we'll take it as a bundle. Fatima.
I don't object. It was just to flag that there's an opportunity for us to link in the newly established EDI oversight group in with the committees to progress some of the EDI work. It's still evolving, and also some of the outcomes from the EDI strategy will also be part of some of the terms of reference. So it's just to flag we're on it and it's coming, and to build that sense of FOMO.
Thank you. Okay, and that's built into our terms of reference. So colleagues, we're happy to sign off those terms of reference? Yes. Are we happy to sign off those proposed work plans? Yes. Okay. Thank you very much. I'm really grateful to everyone involved, including Laura and the governance team, on that piece of work. Okay. So move on to item 18. This is a risk management policy and framework. This is a sort of minor change, isn't it, before a bigger change. So I'll hand over to you, Laura.
Thank you. Yes, as you say, this is more of an interim amendment that we need to make to the policy and framework. We are intending to do a much more comprehensive review of the policy during the next few months when the new ICB risk management team come into post. But we do need to make a small number of changes at this point as a result of the internal audit reviews. So there are just 3 that are set out within the cover paper. So one is to change to the new quarterly cycle to match the new governance cycle. There's some changes to reflect the new operating model, particularly locally for the governance team, so it changes some of the terminology around that. And thirdly, there's just some additional information about how we escalate provider collaborative risks and the role of internal audit. So they're quite minor amendments, but they're important to make whilst we do the bigger review of the next few months.
Thank you. Does anyone have any questions at all? No? Are we happy to approve that? Okay. And we note that's work in progress, really. Thank you. Okay, we are now moving on, Jonathan, to you. Bear with me on our financial plans, which is item 19. So we have a full document. Would you just give us an overview, Jonathan? And would you remind us who you are as well, just for people watching the meeting?
I will. I'm Jonathan Webb, Director of Finance and Deputy Chief Executive. So this next paper sets out the financial plan for 24-25. It should be sort of seen as a part of a suite of plans alongside the operational plan, the workforce plan, and is all designed to deliver the 4 strategic objectives of our health and care partnership. I think it's important just to remind ourselves of the principles that we agreed as a board. So we said whatever we did in terms of our financial planning, recognising that this year was going to be challenging, that we would not compromise patient safety. We would ensure that we tested any choices and decisions for consequences and mitigations. We'd continue to ensure as a partnership that the plans were owned by us and were credible and deliverable. It would utilise peer review and mutual accountability to review and stress test our plans. So the financial plan itself was signed off as part of an urgent decision process on the 20th of May. We, as a system, were set a £50 million deficit control total, and we submitted a plan that was in line with that £50 million deficit. I should note, just for clarity, that does assume that we receive £14 million worth of PFI funding support, which we require related to a technical accounting adjustment in terms of how PFIs are measured on our balance sheet. So within that £50 million deficit as an ICB, so as an ICB as a statutory organisation, we have planned for a £21.6 million surplus. That £21 million surplus sits differently across our 5 places, and I should point out, as contained in the slides, that does include a system risk that we are holding of £17 million. So that £21.6 million surplus is offset by a combined deficit in our NHS providers of £71.6 million. So of our 10 West Yorkshire NHS providers, 4 in deficit, the rest are in break-even or surplus positions. As noted previously in the Chief Exec's report, we have a stretching efficiency target to make this year of 7.7%, or £434 million, and we'll continue to monitor that through the system arrangements that we have alongside organisational review and place review. The final plan was submitted on the 12th of June. We also submitted our operational capital plan that saw us fully commit our £178 million of operational capital that we will receive in 24-25. The final thing to say, and this missed the deadline for papers, but we have since received a letter from NHS England that sets out how we'll be provided with non-recurrent cash support this year to allow us to manage that £50 million deficit, particularly in our provider sector, not exclusively, but predominantly those with deficits. We've also had confirmed that despite us having a deficit, there is no change to our capital allocation for next year, and if we deliver our plan, we will not be required to pay back that £50 million worth of non-recurrent cash support that I just alluded to. So hopefully that's a fairly succinct summary of the plan, Cathy.
That's great. Thank you very much. I wanted to invite Brendan on behalf of the Cute Trust just to talk about the work that they're carrying out at the moment on efficiency and productivity. Brendan, would you introduce yourself just to remind people watching the meeting?
Hello, Brendan Brown, the Acute Trust representative. I think to the Chair's comments, I've talked before about the productivity piece and facing into this conversation. As a group of Chief Executives and Chairs, we've commissioned an external review to test out how far we've gone with some of the work around the fiscal environment that we find ourselves in, and as Jonathan has described. We've gone to a procurement exercise. We were looking for NHSE colleagues to undertake this exercise, but they're actually busy doing this elsewhere in the country. PwC, who are known as one of the Big Four, have started a piece of work with us last week. It's a 4-week short targeted piece of work across the 6 organisations that is currently underway, and I'll report accordingly. But we do need time to process this, and this will need to go to the individual boards of each organisation.
Thank you, Brendan. Does anyone have any questions at all? We're being asked to note this financial update. You remember that links back to the urgent decision on the 20th of May and our extraordinary board meeting on the 19th of April. Jane?
Just a question, actually, just following on from the update from Brendan, in terms of the work that PwC are doing. Do you think that is going to be largely about giving us confidence about delivering the efficiencies that we've assumed within the plans, or do we see that there may be further opportunity over and above the efficiencies that we've assumed in these plans?
I think all of those, Jane. I think it speaks to leadership and culture, but it also speaks to what's going to happen next year and the year after. And there's something about a bridge here for the medium-term plan. So we can be very. I think the environment we're operating in can lead to a short-term reaction which won't be healthy. I think this is about testing ourselves out and testing the collective culture out.
So I was just thinking, so will that come through to FIPSI or Transformation Committee, both? Or where will that sort of, because it'd be really interesting, I think, for us to see and understand.
I think we'll come back to you on where it needs to. I think we need to take it through our boards first. I think we need a conversation with our individual boards, and then I'll pick up a conversation with Jonathan about where that sits.
Okay, thank you.
Okay, thank you, Brendan, for that update. So, colleagues, are we happy to note the progress at the moment? Sorry, Hannah.
Sorry, thank you. I suppose just to, going back to the BAF, the Board Assurance Framework, and that risk around decisions we take related to finance impacting on inequalities and how that's brought into the process. And I was going to mention it at the performance report, but I didn't. But I suppose, I think you talked about it at the last meeting about the equality impact assessments, but just understanding, yes, we've broken even with our finances last quarter, but are we clear what the impact of that was, particularly from an inequalities perspective?
Bev, would you respond on that, please? Thank you, Hannah.
Of course, yeah. So, Beverly Geary, Director of Nursing West Yorkshire ICB. I think I spoke... I've spoken at detail, I think it were at the extraordinary board, around what we were doing around the EQIA. We've reviewed all of the processes in each place because there are detailed processes for EQIA and QIA in provider organisations. There is oversight in each organisation. We've reviewed at place, and as I've said previously at this board, we also have a West Yorkshire EQIA. We brought a really detailed paper to Quality Committee describing the process, looking at the offer around support for individual organisations, because that was, I think it became apparent really quickly that there were different processes, and we quickly, said, well, that's okay, because different organisations work in different ways. But there was also a different level of maturity in different places in terms of the support that they required and training. So we undertook I would be stretching it if I said a training needs analysis, but we asked what the requirement would be in each place. We soon got to the position that actually there's no one size fits all, and therefore what we would do is we would provide support bespoke from the teams at place or from West Yorkshire if that was if they were required and they would ask for it. In terms of the oversight and potential impact at West Yorkshire level, we've got a business meeting, a nursing business meeting. All the directors of nursing are in each place-based quality committee or the relevant committee that looks at the EQIAs and QIAs at place, and they aggregated across their provider organisations. And we'll list at that business meeting the conversations that are taking place, and if it is determined that actually this could have an impact of any type of population across West Yorkshire, then we would agree which committee, subcommittee, or indeed if it needs to come to board, that's what we will do. We'll determine that. I think that's a fair assessment of what was discussed, is it, Becky?
Yeah, we've got we're on the agenda. If you look at our work plan in December, the sort of question that the Quality Committee is going to ask is, so what's the impact of any reductions, any changes to our finances on the quality of care? So we're trying to bet it. So that's the conversation we're going to have with whatever data we can. But it's on the Majid, over to you. It's on the December board Quality Committee meeting.
Thank you. And this is very consistent, Becky and Bev, of what you've said as we've looked at financial plans for 24-25, at least since January this year, on making sure we understand the consequences. And thank you for the question, Hannah. Did you want to come in, and then we'll go over to Fatima?
Yeah, I think we need to keep asking the question. So these are plans at the moment, and I think I was really taken by Duncan Cooper's example this morning from Bradford of the health inequalities card, where everyone's got a card they can say, what does this mean for health inequalities? Are we keeping that in view? I think we should remind ourselves that when we sign these plans off, the performance targets that went alongside them were an improvement on where we were last year. So in general, things should be getting better, and we are recovering. I think that's what the annual report says. That's what we keep talking about. Things are difficult. We're making them better. If we look at the plans and they start to go off and things start to get worse, or if we start to see in some of the indicators through the Quality Committee that things are starting to get worse, we should really have a genuine and robust conversation here, I think, about where are we targeting our efforts. So let's keep it on the agenda, but recognise that I think that's where we are with the plans.
Fatima, did you want to come in?
Yeah, it was really to emphasise, Hannah, just how many conversations we've had about EQIAs. I mean, I don't know whether you saw the reactions, but we in every meeting I've sat in, we've definitely challenged and asked the question. What we've also tried to do to support the decision making of, it doesn't matter whether we're stopping something, even when we decide not to do something, we need to factor in what the potential implications might be. So Ali, who works in one of my teams who leads on equality transformations, developed a flow chart to support the work that Bev and colleagues are doing too. So we're very much trying to triangulate as much as we can in the system to support work that's happening in places too. So very much on it, but like Rob says, we still need to keep an eye on it.
Thank you. Just this term's been used, EQIA. Could you just explain it, Fatima?
Equality, Quality, Impact Assessment.
Thank you very much. Okay. Colleagues, are we happy to note the financial plan? This is a watching brief for us all across places, provider collaboratives and at board level. Okay. Thank you. All right. And thank you to everyone for the work that's ongoing at the moment. And we note that we had a discussion in private this morning about our financial plans as well and looking at risks. Rob.
Sorry to extend this a bit, Cathy, but I do think hidden in the comments that Brendan made, I think was reference to the medium-term financial plan work that we've been doing. And I think we need to just see this plan, which is tough and challenging, in that context. And the board needs to keep coming back to the medium-term financial plan. And I think we need to get that into the agenda explicitly in the next few months to make sure that we're having that conversation.
Thank you. And when we've been talking particularly to our colleagues who are delivering acute services, this was a very strong request. They're doing their best on their own 2 to 3 year sustainability planning. We've talked in our development session this morning and in our discussions in private and public today about sustainable healthcare. And I think this is something we also asked NHS England national team for their support as well. Brendan, do you want to come back in?
Well, it's only we rightly talk about the impact for our patients and their communities, but we should be talking about our colleagues who are finding themselves in an invidious position, having to make decisions and plan for, I think the language we used was doing more with less, that has an impact. So I've talked before about we will do all of the assessments that we can to look at how we mitigate the risk, but it's the decisions have got to be made, and we're putting our people and our leaders in difficult positions because of the context we're operating in.
Turn my microphone. The Why at Work will identify, I know that you're looking at productivity, efficiency, particularly in line with NHS England's requirements and expectations. But your point there is also looking at the impact on staff, services, residents, their carers and families as well. There's trying to look at it in the whole is what I'm picking up from you. Yes, you're nodding. Great, thank you. Okay, we'll continue that discussion. I'm going to move us on now, Jonathan, to item 20, the ICB budget book. We are being asked to approve this today. Would you give us an overview?
I can, thank you, Cathy. So this is a supplementary paper to the financial plan. So the scheme reservation reserves the power to approve the budget book to the board. What the budget book does is take our overall financial plan and breaks it down to a series of budgets through Rob, through the director team, and then to budget managers and budget supervisors. And it's really just brought for approval today, Cathy. I'm not sure there's anything else I can say.
Okay. Colleagues, are we happy to approve that? Yeah, nods around the table. Thank you very much. Okay. Thanks, Jonathan. Can I come to you then on the capital resource use plan? This is being asked to note as well as approve part of it. Would you give us an overview?
I will, thank you, Chair. So just as we will be submitted or have submitted our financial plan to NHS England, which included our revenue plan and our capital plan, a requirement was introduced last year to do a narrative supporting version of the capital plan for the system that's approved by not only the ICB but also the 10 provider trusts in West Yorkshire. So the format is set out by NHS England. It sets out how we are going to deploy our £178 million worth of operational capital and other national schemes. It's been reviewed by the Finance Forum, it's been reviewed by the Finance Investment and Performance Committee. It then got a second review through the Finance Forum, through each of the 10 organisations, and it's brought today for approval.
Does anyone have any questions at all or comments on what Jonathan is presenting? Becky?
Jonathan, the Quality Committee holds the risk on RAC at Airtel, which is an interesting one for the Quality Committee because of its capital issues. But mindful of it taking 11 years to get an A&E built at Huddersfield and how long it's taken to get a decision about Airedale, we're 6 years off. The building being non-viable, or you just can't use it in 6 years' time. So without any major other risks, and walking around Airedale with the props, it doesn't feel like that feels a long way off. So how confident are you that we'll get the money and the plan to be ready in 6 years' time? That feels very close now.
Yes.
Can I just ask you, Jonathan, just particularly for people who are watching the meeting, to explain what's within our control and where we're reliant on national funding sources, including national government?
Yeah. So we've got 2 live schemes at the moment within West Yorkshire that are part of what's called the new hospital programme, Airedale being one, Leeds being the other. We had a conversation at our annual review meeting with NHS England about a week and a half ago to get an update on what the approvals were and what the progress will be around those 2 schemes specifically, particularly given the election. And I think that's probably all I can say at the moment.
Yeah. We have to note that we're in a pre-election period and funding flow through new hospital programme, please correct me if I'm wrong, relies not only on NHS England but it's worked with Department of Health and Treasury.
It is, it's a ministerial run programme.
Yeah, on the funding flows. So we note that we have Airedale and Leeds Teaching Hospital Trust receiving new hospital programmes money. Nancy, would you introduce yourself? And Airedale's come up, which is a trust on your patch.
Yeah, Nancy O'Neill, Bradford District in Craven. I just wanted to make the point that irrespective of the vagaries of the money and what might come through, the planning for Airedale Hospital new build continues. And so that's working across the patch as well to say what's the implications of having a hospital at one end of the patch has a ripple effect to the other trusts and the other community services working across there. So we're still planning for that because that then, of course, will shorten the time when we get the green light to go ahead financially.
Thank you. So we are in a pre-election period, but we await new government to be established from the 5th of July and to understand policies going forward. Rob?
Yeah, I think we we should recognise that as a board, we're in the new hospital programme. There's a sum of money that's been promised, which we're using to plan for. That sum suggests that there will be central procurement savings by being in the new hospital programme, which are substantial, and that as a system we need to make pathway savings of having a new hospital. So we have to plan for all of those things irrespective, I think. And as Nancy said, I know that the ICB colleagues in Bradford District and Craven, the Trust colleagues and the central team are all working together on what those plans look like. We should probably think about, well, what needs to come here when, because this is about, it's not just about Airedale, it's about Bradford Teaching Hospitals, it's about the community services around the system, and it's around the degree of risk on things like that procurement efficiency that we need to be cited on.
Okay, sorry everybody. Are there any other questions on the capital plans? Sarah?
Yeah, I just want to acknowledge there's a heavy reporting burden being placed on the ICB to keep reporting in different formats the same information. The one thing we've always been really clear on is what are our priorities in terms of our capital needs across the whole sector, and trying to work within the different streams in which capital funding gets allocated. So this doesn't change with each new plan, it just needs to be put into a different format. And when you've got subsequent meetings with NHS England, and as we know, whatever happens post the election, just sharing, just asking to keep submitting different formats of reports that says the same thing doesn't actually give us any more money to do the things that we need to do. I just felt compelled to say that because of all the work that we've done on the infrastructure plan, and then it was like, oh, we've got another report. So,
thank you, Sarah. Noted. Jonathan, would you let us know what happens next? We're putting a strategic plan together. We're working with NHS Property Services.
Yes, so we are,
could you put your mic on?
Yeah. So we are in the middle of a wider piece of work to look at our 10-year infrastructure strategy across the ICS, and we will be bringing that back to a board meeting later in the autumn.
Thank you, Jonathan, and just noting Sarah's point on making sure we're not duplicating and wasting effort. Okay. Thank you, colleagues. So are we happy to approve this, and we note that this will be published? Colleagues, are we happy? Yep, thank you. Oh, Jane, sorry.
I was just thinking in terms, I mean, that report, there's loads of stuff in there, and it's clear that, you know, we've got lots of things either that we've bid for, things have come out of the one system going in elsewhere. So it's quite difficult to sort of unpick, I think, to kind of get a sense as to kind of where our level of confidence currently as to where some of these things are. So I did wonder if there's a kind of RAG rating or something that we could apply against each one, so to help us read and see which of these or what percentage of these we think we've got confidence in versus those that are back in the loop to try and find alternative funding sources for. I think it says it in the narrative, but it's quite difficult to unpick.
Okay, versus the priority. Because sometimes it might be the biggest priority,
yes.
but it doesn't have the funding.
Yeah.
Okay,
Yeah.
Thank you. Jonathan, is that possible?
I'll ask the team. But yes, we'll have a look.
Lovely. All right. Thank you very much for that discussion. And capital has been something we've discussed across the whole system since we formed as a board. We note that Airedale's, this is when I have to remember what RAC stands for, reinforced aerated autoclave concrete, thank you, Rob. It is a system risk, and Nancy was talking there about it's not just for that trust, it's how it affects the rest of the system as well, not only in place, but also for acute services. Thank you for that discussion, and we'll continue that as the strategy comes out. So we move on now to our Committee A reports. In some ways, by putting them at the end, we should have covered a number of things through looking at the Integrated Performance Report, the Corporate Risk Register, the Board Assurance Framework, and hearing updates from colleagues around the table. I would still, though, wanted to invite anyone who has their name against one of these AAA reports, if they want to provide an update, something maybe that has developed, changed for the positive or negative, as well as any questions on these reports on the AAA. We can see themes around finance, concerns and challenges. We can see themes around good governance reviews taking place, which we've talked about earlier. We can see some places looking at cancer services, and we've had a report on that earlier. But I don't know if there are any updates at all from colleagues around the table. Becky.
Just back to primary care and scheduling. So we had the session at the Quality Committee. It seems to be it's also on the Transformation Committee, and then it's also on. I'm just back to thinking what you're saying about how many times do you report about what. So just some consideration about the necessity of the one in July if you're coming back into the board in September. A little bit of hygiene around that would be helpful. I think just to note that we in the Quality Committee review complaints from the public. And since we're in public, it felt like a good time to recommend it. We had a big increase. We're not sure if it's a pre-election increase, and there seem to be absolutely no patterns and trends at all. But we will be, well, you will be, inviting our MPs that are elected after the 4th of July for a briefing about what we do and how we do it, and how we're addressing complaints. And Laura, thank you for being the actual sort of chief complaint manager and handling people so incredibly well. But obviously most of the complaints we get are usually around primary care issues. So we are, of course, handling that in the committees very well, but the Quality Committee does review all of those. And if there are patterns and trends, we will bring them back to you, and particularly for that meeting. Thank you.
Thank you, Becky. That's really helpful. And thank you to Laura and to many colleagues who are making sure that our complaints are noted, acknowledged and responded to fully. Are there any other updates from either place committees or West Yorkshire committees at all? Is there anything that people want to share? Jane?
Yeah, it's just one general comment, because I think in one of the internal audits on governance, it may be in the governance framework or it may be in the BAF, but it did, the work and their assessment did look at how we are using the AAA reports incoming, and they are seen as a really key element of evidence to discussions, etc. So I do think, making sure that, because often we do come to them at the end of the meeting, ensuring that colleagues do sort of draw out some of these points. I'll do it on audit committee just to sort of be an exemplar, but I do think it is expected that there is a little bit more of a sort of discussion prompted by the reports, particularly obviously where there are alerts that are brought to the committee. Obviously, from an audit committee perspective, it's been heavy lifting over the last few meetings, but we've got 3 AAA reports, and within that, and some of these things, we need support from colleagues around the table and within your organisations and teams. So internal audit, I would say, with Audit Yorkshire, we had challenges in terms of completing last year's audit plan, significant challenges. 60%, I think, of the reports came to us after starting the new financial year, which is not ideal. So we have a new audit plan that we've signed off. It is, I think, on all of us to sort of try and smooth that process in terms of sticking to the timelines that colleagues have agreed to, and that will involve teams within the place organisations as well. So it's just a request for support on that. It isn't helpful for us in terms of getting a sense of assurance if all of them come at the end of the year. And obviously things should be going through FIPSI and Quality Committee ahead of that. I think in terms of, I did also want to actually call out, because we didn't mention earlier, the great work that's been done in terms of data security, information data protection. We look at that a lot in terms of Audit Committee and the progress on that, and we have external requirements for that take an enormous amount of effort from colleagues in Laura's team. And again, we've got good assurance, but it's kind of quite, well, we're not quite submitted it yet, but so it's pleasing. But obviously people need to be really mindful of that. We talked about cyber risks, etc. earlier. So I would encourage people to do that and basically put the support behind that. But I think I just wanted to draw attention particularly to those areas which we probably haven't discussed as much earlier on the agenda. There was another one. FOI was one recently that we talked about, in one of the other governance. Freedom of information. Freedom of information queries that come in. So we also look at our responses to other governance elements at Audit Committee, and there certainly has been quite a few breaches in terms of our deadlines to respond to those. Again, it doesn't all just sit in Laura's area, and often it requires responses from colleagues across the board. So if people can just feed that back to their teams, the importance of being compliant in that space, I think that would be much appreciated. Thank you.
Jane, thank you very much. There was something on your audit report that I wanted to invite Kate to talk about. You were talking about the actions from the ICB staff survey taking forward. I don't know if we invite Kate at this point just to come in, because that was something the Audit Committee picked up. Kate.
Thank you. So I think this is this with the reference to the fact we've had an audit that was limited assurance. Just to qualify and clarify for everybody, this related to the staff survey that was undertaken in 2022, and then we developed the action plans last year. So we have local action plans for each of our places and for each of our directorates, and then we also have the sort of overarching one. And the audit report reviewed how active we'd been at monitoring those action plans and reviewing those. There was some good practice, but I think particularly the overarching comment was that in the vast majority of the sample of places and directorates that were looked at, and indeed for my own sort of team in the People Directorate, there hadn't been as much formal reporting around the monitoring that was happening. I think it goes back to something that we've touched on a few times today, Chair. The action plans were signed off early last summer, and it was right at the start of us all spending our time focusing on our new structures and identifying those. And then, of course, we launched our big organisational change programme in late summer last year. It was helpful. Obviously, I think our auditors absolutely recognised that there were overlapping and over-competing sort of priorities at the time. What it has done, though, for us as an EMT is identify, making sure we're really clear, both locally and for the overarching action plan, what it is that we're focused on. I mean, there was a huge amount of engagement last summer and beyond with our staff. And I think we kind of listened at the time to the priorities being people concerned about their future roles. That's not to say there wasn't some practice that took place, you know, to undertake actions from this. But this year, you'll all receive it. We've signed off the action plan as a group, and there will be sort of that regular updating. So the processes are absolutely there. It's just now we need to focus back in on it, if that's helpful. Thank you.
Thank you for that update. Is there anything else on the AAA reports, Majid?
Just building on Jane's point.
Would you bring the microphone closer? You can pick it up.
Okay,
yeah, thank you.
Just building on Jane's point about the audit reports and the AAA reports, it's about linking back to the board assurance framework and risks as a matter of routine. So I think there's a suggestion somewhere that we might produce a bit of a guide, so we've got consistency in the AAA reports in terms of content, etc.
Laura?
Yes, I think so. There is a guide, but we think we can probably strengthen it further by adding in some other reflections around things that'd be good to capture. So we're working on that.
Okay, thank you. Someone's just sneezed in the room. The acoustics exaggerated it. Okay, and we also know Calderdale have a new finance subcommittee, which is further in line with other committee. No, have I got that wrong? Sorry, Neil.
Sorry,
and then we'll go over to
so
Leeds.
I think it makes references to that we're looking to develop it in July, and we're considering options, so it hasn't been set up yet.
Okay, thank you for that clarification. Tim, would you introduce yourself, and then we'll go to Joe in Wakefield.
Thank you, Cathy. Chair, I'm Tim Riley, Place Lead for Leeds. 2 comments. One, just I think the conversation we had earlier around the BAF and using that consistently across places and using it to set agendas and so on will probably help strengthen the AAA reporting. It's actually really hard to know what to put in those boxes sometimes at the moment. So I think that will help. And just then one other thing, the last Leeds committee, and you'll see one of our alerts is around finance, and particularly with reference to inequality, to third sector and so on. We held that meeting on the day the election was announced, just at the end of the meeting. And we did have another meeting planned for the 26th of June, I think, to go through some of that inequality and look at the impact that might have had. We would want to do that in public, but we didn't think that was appropriate in a pre-election period. So it has been put back to our September meeting. But I think it's important that people are aware that a place is looking at that quite seriously. We couldn't take it forward, understandably and quite rightly, given the election.
Thank you, that's helpful. Joe, would you introduce yourself?
Yeah, Joe Webster, Place Lead for Wakefield District. I just want to echo what Tim said about the sort of conversation that we had around the board assurance framework, sort of structuring our conversations in our places. And we've started to think about how we might do that in Wakefield. But just that sort of introduction to this section, I'm just looking at the things that we want to assure and advise people today on, triangulate back to the performance report in Wakefield. So if you look at some of our significant increases in demand around our performance around A&E targets, our length of stay, and look at the challenges that we're seeing in Wakefield and how we're addressing them by improving by identifying them as risks. That's the triangulation. So I think there's always some things that we can do better and improve on how we report through these reports. But just to give confidence back to this board, that I'm sure that me and my colleagues are having the similar conversations to what we're having here today, locally in our places.
Colleagues, thank you. We'll continue to move around the committee AAA reports to test out where they fit. So we have done it before, straight after the corporate risk register, for example, so it takes it as a bundle on performance, corporate risk register and the AAA report, so we can try that for September. We are constantly wanting to take on board the feedback from internal audit as well as audit committee. Okay. Colleagues, before we finish up on this section, is there anything else? There's a huge amount of information, of great work going on across places and providers. Rob?
Yeah, so similarly, I think it's worth reflecting that there's a huge amount of work going on, and I was just struck by the amount of work that's going on in the places around making the places work effectively. So Neil just described changes to some of the committee structures that they're considering. We've had discussions about what's going on in Bradford Place, and you can see from the report some real changes, particularly around the money and the managing the gap. We know that in Wakefield we're doing a bit of work around what's going on with how do we collectively lead in Wakefield, and for each of the places we could draw some conclusions. And it might be that we need to take stock at some point of the fact that we started in one place with all of these different arrangements and they've continued to mature and develop. So where are we now with each of those? And it might be worth us thinking about that at our next sort of strategic session, Chair, so that we can take stock, think about how each of the models are working, and look at that in the light of the conversations just had around the governance and the significant assurance that we get through our governance. And the budget book that we just signed off, which continues to give all of the money pretty much to the places that are sitting around the table.
Thank you very much. That forms, we're aiming to have a board development session next month and then another one in October as well. So I think what we've got here is board development sessions looking at the board assurance framework, linked to places, and then also a whole theme around capital estates as that strategy comes through as well. But there are a number of other things we'll look at. Anything else on AAA reports? Otherwise, I'll close that item. Okay. Do we have any other business around the table? No. Okay. We have had a packed agenda today. I was trying to keep up. The amount of things we even just want to go and talk to regional and national colleagues has taken up. There's a big list there on things that we want their help with, which we will take forward. We've got a number of themes around reviewing data and reporting linked to inequalities, continued sharing of best practice, and a good discussion on risks that have been highlighted in the reporting, but also that colleagues have highlighted around the table. We are in a pre-election period, which means that there are certain things we haven't been able to talk about today, including forward planning or influencing work that we might want to do. But when we meet again as a partnership board, our Integrated Care Partnership, which will be on the 16th of July on MS Teams, my little plug and promotion there. Please come along if you're a member of that, and please encourage colleagues in your places to come along if they're members. And then we will have our next board meeting on the 24th of September in Kirklees, where we can bring that together, and we will then have our focus on topics on reducing inequalities in our board meetings in public as well, complemented by a board visits programme. Colleagues, thank you so much. There was a lot to get through there today, particularly to support our governance colleagues and the work of our audit committee and our finances as well. Thank you for your preparations for this meeting today and your contributions. Becky, thank you so much. This is your last board meeting. We're really grateful to you for your advocacy, activism and support and commitment to communities and our work with us. We're really grateful to you. And we were going to celebrate you after this meeting as well. So, colleagues, thank you. See you next month for a board development session, and then see you in Kirklees for our next board meeting. Thank you, and that's the end of our meeting. And thank you for those who have watched our meeting today.